Lake Town Synergy is a congregation of enthusiasts who have come together for the cause of diabetes. The organization works in the area of diabetes awareness through seminars organized in schools, colleges, and corporates. Mass campaigning occurs every year during the World Diabetes Day celebration. It works within its resources to take 360-degree care of few type 1 diabetic children till they attain economic independence. Rural diabetes detection camps, outreach clinics once a month were a regular feature of the pre-COVID era. The organization also tries to propagate knowledge amongst the doctors through CMEs round the year, and the epitaph of such programs is the Charles Best Memorial Day in the form of ENDIAB Summit, where it is a gala scientific extravaganza dished out by regional, national and international speakers of repute. Hope you all enjoy the academic feast over the coming times. Hello. Hello.
So we are live.
Okay. Good evening, delegates, and it's 6:59, and we are going to start just at 7. Thank you, everybody who have supported us throughout all these days in the preparatory phase, and all the faculties and delegates who would be joining us for this conference. So we start the proceedings with a message from Professor Anirban Mojumdar, who is the president of Charles Best Memorial Committee.
Good evening, friends. Welcome you all on Charles Best Memorial Day. Charles Herbert Best was a medical student when he joined with Frederick Banting about 100 years back. And because of their endeavor, they discovered the insulin, which is one of the most fascinating discovery in the medical history of the last century. The discovery of insulin actually had provided a new lease of life to the millions and millions of diabetic subjects all over the world. To remember him, every year we observe Charles Best Memorial Day in February since 2014. This is the 9th year, and in this occasion we have ENDIAB Summit. This ENDIAB Summit has been divided into 3 parts. On the first 2 days, we'll discuss about the diabetes. On the third day, that is next Sunday, we'll have discussion on the common endocrine issues which we face regularly in our day-to-day clinical practice. So friends, I welcome you all for the Church's Best Memorial Celebration and to enjoy the ENDIAB Summit, which we will going to observe today, tomorrow, and day after tomorrow. Welcome you all and enjoy the conference. Thank you.
Thank you, Anirbandha. Thank you for that wonderful piece of information. And thank you for welcoming all our delegates and our honorable speakers. And what can be more appropriate than our organizing secretary of Child's Best Memorial Day ENDIAB Summit 2022, Dr. Ajoy Biswas, taking us up for the first talk. Well, Dr. Ajoy Biswas will be talking about sitagliptin in elderly and in special situations. He is DND Medicine, PhD and postgraduate certification in endocrinology from Royal College of Physicians, London. He is a consultant physician at GD Diabetes Center and faculty in endocrinology, University College of Sciences. Over to you, Ajoy, to take us through the topic of the day.
Good evening. Thank you, Lepton Synergy, for inviting us on this wonderful academic summit, ENDIAB Summit 2022. We are looking for really exciting academic feast covering multiple aspects of diabetes and endocrinology with recent advances for all of us. The first session where I am going to talk about sitagliptin, its effectiveness and safety, especially in elderly and special considerations. As we all know, we've been using sitagliptin more than a decade, and especially in elderly population, there are certain considerations. We'll have a very quick run through around the current scenario, our treatment goals for elderly, our challenges in meeting such challenges, and role of gliptins in elderly, especially in terms of its efficacy, its overall safety in terms of renal, cardiovascular, bone health and neurological issues, as well as adherence issues, and also the lower risk of hypoglycemia that this particular class of molecules are very well known of. Now, as you all know, you can call it a treatment success or advancement of therapy. The world is growing older. The population above the age of 65, around 8.5%, around 670 million in 2016, is expected to double to 17% by the year 2050. And the global population of the oldest old, that is above 80, very, very senior citizens, that is expected to get triple by the same time. And it is not surprising to note that non-communicable diseases are the main concern in such population. And naturally, type 2 diabetes remain the commonest chronic illness in such population. 1 out of 4 in that population is either having a diagnosed established type 2 diabetes mellitus or yet to get diagnosed undiagnosed type 2 diabetes mellitus. And cost of diabetes care, if we include both the components, the direct medical treatment cost as well as the loss of productivity, then it amounts an enormous quantum, an enormous challenge to our healthcare setup. In fact, up to 60%, almost up to 60% of our healthcare expenses are probably getting utilized across the globe for the care of these elderly diabetic subjects. Now, as you all know, there is a very steady, stable decline in beta cell function across the ages. Now, if we study in this patch clamp study, it was shown from age 20 to 70. If we look into insulin release and corresponding insulin sensitivity, there was a steady decline noted in progression of age. In terms of the first phase of insulin release, it was around 3 times faster decline, while for the second phase of insulin release, it was twice. It was more profound in patients having impaired glucose tolerance compared to the normal glucose profile. Now, even in such population where secretagogues are not expected to have their efficacy because of the declining beta cell mass, sitagliptin monotherapy in elderly have been established in certain therapies, multiple studies that they retain their effectiveness. And from a base level of around 7.8% A1C, they can contribute to a statistically significant A1C drop, a glucose drop corresponding by 20.4 milligram even within 3 days. And this effectiveness is age independent. There is a study in Japan, assist case study, where they have divided the population, around 1,000 patients were included, and they have divided the population into 3 different groups: less than 64 years, 65 to 74 years, and above 75 years. And it was shown quite consistently that the decline in A1C was around 0.62% or 0.6% or 0.53%, more or less pretty consistent, and there was no significant difference between the 3 subgroups. Now, you might be surprised to note that sitagliptin, in fact, is more effective in poor beta cell function, because in a person having depleted beta cell, you can see there is alpha predominance. So a drug which counteracts that glucagon axis is expected to be more efficacious. So naturally, if we go by the HOMA-beta assessment and effectiveness, HbA1c reduction and HOMA-beta correspondence, we can see sitagliptin retains its effectiveness, even more effective in such beta cell depleted subjects. Now, longer duration of diabetes is associated with a decline in EGFR. It's a kind of natural history, we can say. As the time progresses, from 30 to 40 years of age band, the process of decline begins, and it progresses around 0.5 to 1 ml per year. So naturally, once the diabetes duration is quite long enough, our choice of molecule is also restricted. The dose we use is restricted by the EGFR of the corresponding person. Now, sitagliptin in all 3 doses, be it 25 or 50 or 100 per day, been shown to be effective in elderly across the age band, across the EGFR categories. And you can see it could achieve the correspondingly proportionate A1C reduction in all 3 subgroups. And most importantly, over the follow-up period, there was no apparent change in baseline renal function. So probably we are having on one side a safe, durable glycemic control, also a preserved renal profile. If we go into this data where we had basic CKD patients having severe renal impairment patients and those who are having ESRD on hemodialysis, the choice of sitagliptin, the dose of sitagliptin, that was either 25 or 25-50 milligram per day. But you can see the proportionate HbA1c reduction and safety efficacy maintained in all 3 subgroups. Now, sitagliptin versus sulfonylurea, if we compare them on another very critical aspect, there's a reduction of urinary albuminuria. Now, the categorically in this study, we have seen those patients, around 1,000 patients were included having USCR more than 30. Sitagliptin was compared to sulfonylureas. It was shown significantly, statistically significant reduction, 15% reduction in urinary albumin creatinine ratio with a persuasive p-value of 0.001. And sitagliptin demonstrated increased USCR reduction, almost 20% larger USCR reduction compared to sulfonylureas. Now, TECO study, we all know, published in way back 2016, it showed unmatched safety profile of sitagliptin. Though the adverse effects, as one can expect, was more in elderly, more in CKD patients, but there was no evidence of adverse impact on the safety of endpoints in CKD patients, be it severe hypoglycemia, be it fracture, be it pancreatitis, be it malignancy. Over 4 years, eGFR was preserved and the adverse effects were within the acceptable norms of safety limits. Now, naturally, as we've been talking about hypoglycemia, that is one of the most dreadful, life-threatening complication that we want to get rid, especially in elderly. Why so? It is really very difficult to recognize in elderly because symptoms are often non-specific. It is quite easily misdiagnosed as vertigo or visual disturbance or suspected stroke. Often it's misinterpreted as a dementia-related symptoms or an agitation or a behavioral disorder. Its atypical presentation like confusion or delirium is often unnoted or missed to be picked up. And little warning sign or hypoglycemia awareness is a big issue. Then patients with dementia are unable to communicate appropriately, communicating their compromise in cognition. Now, naturally, with old age, malnutrition, presence of multiple comorbidities, chronic hepatic or renal dysfunction, presence of multiple acute illness, hospitalization, stroke or TIA or heart failure, or use of rapid-acting insulin, all these make a senior citizen more vulnerable. Polypharmacy, multiple medication drug interactions, blunted counter-regulatory responses, all these contribute. Lack of care facility, social isolation, component of depression and dementia make the whole thing pretty complicated. It was really interesting to observe in patients who were otherwise not achieving their glycemic target with sitagliptin metformin combination when they've been put on glargine. It was seen that those patients where sitagliptin was continued, they had lesser extent of hypoglycemia compared to those who were continued on metformin alone. But why so? Why this stunning thing? Now, probably we need to understand one thing, that sitagliptin or gliptins, they have a fascinating contribution on glucagon axis. If we look into this glucagon insulin axis, glucagon gets suppressed in hyperglycemic state in both healthy as well as diabetic patients. Now, hypoglycemic state, GIP induces an increase in glucagon concentration, but not GLP-1 infusions or saline infusion as shown in this study, thereby augmenting the endogenous glucose production. This was associated with a reduced need for exogenously added glucose to prevent hypoglycemia. This was a very pioneering study published in 2016, and these have shown probably the mechanistic basis how these sitagliptin or similar gliptins confer some protection against hypoglycemic incidences, especially in elderly or those having multiple comorbidities. Now, naturally, in an elderly, we are afraid of cardiovascular disease. Aging is quite synonymous with progression of cardiovascular disease or new onset of cardiovascular disease. With advancement of age, there are certain changes. On one side, there is increased fatigability, there is muscle weakness and wasting with lack of endurance capacity, limiting a person's physical activity, thereby lowering his or her energy expenditure. Naturally, there is concomitant rise in abdominal fat and obesity, increase in insulin resistance, contributing to the worsening of hypertension, atherosclerotic changes, dyslipidemia, worsening of glycemic control, and final common pathway of progression of cardiovascular disease. Now, old age is definitely associated with worse outcomes, but TICOs have categorically shown the comparison of event rates. In old age, we had significantly higher heart failure, hospitalization for heart failure or death. All-cause mortality was 2.5 times, while heart failure related admission was or death was twice. More incidence of malignancy, more incidence of severe hypoglycemia, and almost twice incidence of fracture. The primary and secondary composite, cardiovascular composites, were also significantly higher, around 1.7 to 1.8 times. Now, sitagliptin categorically shown, it has established its safety, that there was no worsening of outcome in such elderly population. You can see the confidence limit and use of sitagliptin in elderly was not associated with any further worsening of 3 or 4 point major adverse cardiovascular events, be it hospitalization for heart failure or death or all-cause mortality. Now, glycemic benefit of sitagliptin was adjusted in this study. So in actual, it is really something very robust and persuasive data. There is no increase in cardiovascular events in older patients who've been initiated on DPP-4 inhibitors. Compared to sulfonylureas, this is from the registry data of the Medicare. You can see gliptins were associated with much lower incidences of non-fatal MI, stroke, death, both in elderly patients and those with having established cardiovascular disease. Fracture is one more issue we are worried. It's a potentially explicable variables for the presence of fractures. Now, it was shown that patients with fracture, those who've been on agents, were essentially having low BMI and high osteoporosis and comorbidities. And probably that is something to very seriously consider. Now, fracture risk associated with common medication, if we have a look, thiazolidinediones, our favorite pioglitazone, which has got good stroke prevention data, but was associated either in meta-analysis of the study per se with almost 1.4541 times higher risk factors. Canagliflozin in particular had around 1.32 times higher risk factors. GLP-1 analogs were probably having a mixed data. On absolute value, they had something around 1.05, but meta-analysis on adjustment come to be quite safe, 1.0. While DPP-4 is having probably the safest profile, the hazard ratio having safest profile among the entire class. So if we look into the overall safety profile compared to the other hyped class of molecules, gliptin remains one of the most durable, most effective, as well as safest class of molecule, even in high-risk population, having higher risk of fracture, higher risk of cardiovascular issues, higher risk of hypoglycemia. And naturally, they become our natural choice in elderly and special population. Now, if we look into the bone safety, it was shown that sitagliptin's effect on bone metabolism was predominantly through bone resorption rather than bone formation, as documented by the serum alkaline phosphatase and urinary deoxypyridinoline assessment. Sarcopenia, as we've been talking about, is one more issue, a chronic complication of type 2 diabetes in elderly. Relationship between age and appendicular skeletal muscles have been correlated, and skeletal muscle index across type 2 diabetes for each sex was noted in this study. And it was shown that not only sarcopenia, but also retinopathy had a very strong correlation. And prevalence of sarcopenia significantly increased along with the progression of diabetic retinopathy. It was noted that proliferative diabetic retinopathy was significantly associated with sarcopenia and poor muscle strength. Now, gliptins attenuate this decline of skeletal muscle, and it was shown that estimated change in skeletal muscle index in patients with DPP-4 inhibitor was significantly higher than patients without. It was quite persuasive, 0.04 or 0.03. Now, elderly diabetic having sarcopenia, what is the role of gliptin? It not only provides appropriate glycemic control, also reduces the inflammatory parameters and definitely a much better sarcopenic parameters, be fat-free mass or skeletal muscle mass or related incidents. Now, muscle strength, gait speed, all being compared with the sulfonylurea groups, and multivariate analysis confirmed that better sarcopenic parameters and preservation of lean body mass and strength and physical performance indices were noted with sitagliptin compared to the sulfonylurea. Last but not the least, if we look into the cognitive aspect, if we do a very simple mini mental score evaluation for assessment of cognitive decline and the dementia in older adults, it was shown whether we are looking for Alzheimer's or those without Alzheimer's, sitagliptin therapy was associated with a significant increase in mini mental state examination scores in either of the populations. Now, those having Alzheimer's receiving sitagliptin or insulin showed significantly higher MMSE compared to those who have been on metformin alone. Now, patients with Alzheimer's on sitagliptin showed significant improvement. So not only inflammatory, not only cardiovascular, not only renal or osteoprotective aspects, probably we are also having cognitive protective aspects. And with a very safer profile with very minimal adverse effects, the dropout or discontinuation of drug is really rare with gliptins. So naturally, there is much better treatment adherence than the conventional alternatives, be it sulfonylurea, be it TZDs or metformin alone. So to sum up, in elderly, especially elderly with type 2 diabetes, which is a very fast growing population with unique challenges, presence of multiple comorbidities do restrict our therapeutic choices. Often we fall short of our desirable efficacy or safety requirements. Gliptin's efficacy is age independent, a pretty rational choice to achieve glycemic targets, effective even in low EGFR or those on renal replacement therapy. Low risk of hypoglycemia is really a welcome thing in elderly who are at a much higher risk of hypoglycemia. Generally safe cardiovascular and overall tolerability profile, lower risk of fractures, sarcopenia, positive impact of cognitive decline in elderly makes these incretin-based therapies a better treatment option, as noted by better treatment adherence as well by our patients than other oral agents. With these words, I thank once again Lecton Synergy for inviting us on this platform for this academic fest. Looking forward to a fascinating 2.5 days of academic extravaganza. Thank you.
Thank you, Dr. Biswas, for such a wonderful deliberation, taking us through the journey of elderly diabetes management. A few questions have come in. Can I pass it over to Dr. Ajoy Biswas?
Sure, please.
Yeah. There has been a question where people have asked that more and more surgical procedures are being offered to elderly subjects, as because life expectancy is going, you are having organ replacement, etc. And on the other hand, the time of in-hospital stay is becoming less and less day by day. So at times it becomes difficult, although textbook teaching says that if you are having a operative procedure, you need to be on insulin. So people are started on insulin and then they are sent home with discharge advice on insulin. it becomes very difficult to manage. Is there any role of sitagliptin in such patients by which we can minimize the insulin, etc.? Yeah, I think he's referring to the hospital study from sitagliptin. If you
Essentially, the scenario of using insulin as the only option in hospital scenario has grossly changed over time. And recent studies have categorically shown that sitagliptin, and even more studies are coming where we are having non-severe or non-acute situations. Their combination of even SGLT2 inhibitors along with DPP4 inhibitors are being used for short-term scenario. And not necessarily all admission requires insulinization. For example, someone requiring a surgery for cataract who's more or less controlled with oral agents probably will not require any replacement. Only where we are having difficulty in food intake or having other concomitant comorbidities which may be acute or fluctuating, probably those are the scenario where we need to still stick to insulin. And definitely use of SGLT2 inhibitors in such scenario where acute scenario can influence the higher incidence of glycemic ketoacidosis. One need to be very cautious. Otherwise, probably sitagliptin can cover to a much larger segment where we do not need to.
Thank you. I'll take a quick question before we move on to the next session. Our next delegate has asked that in how often do you find that your patient who has come to you at a tertiary care center or a secondary care center is on an inappropriate dose of sitagliptin? Is it very common?
Inappropriate dose is probably related to the education and awareness of the patient. I came across many people who just self-adjust their dose of sitagliptin just because the sugar level was controlled.
The delegate is meaning that with regards to the EGFR.
Both the versions we see. Normal EGFR taking half dose just because the last sugar report was appropriate, and the sitagliptin being a relatively more expensive gliptin, many people make it half. At the same time, I came across high dose of sitagliptin being inappropriately continued in terms of the lower EGFR range. So both scenario we have come across, and that's a quite common thing.
Thank you, Dr. Biswas, for being there with us. In fact, thank you for organizing this conference. You are incidentally the organizing secretary of ENDIAB. And
definitely,
and I happen to be the secretary to the organizing
for all things that we have done. Thank you.
Thank you so much. And we move on to the next session. I can see Dr. Kalyan Ganguly there, and his topic is very fascinating: preserving the kidneys in the management of diabetes. This has become very important nowadays. Dr. Kalyan Ganguly is MD, FRCP, and a CCST in endocrinology. He is a consultant endocrinologist at the Peerless Hospital and the CK Builder Hospital, and is a prolific speaker at both regional and national levels. And we always love to hear from it. Jubilant, enthusiastic, and what a start to our conference did he give with his bite. Over to you, Kalyan, for your presentation.
Thank you very much, Homo. Let me share the screen. Okay, I hope the screen is visible, and I hope
it's full screen.
Pointer is visible. Okay, thank you very much. So we are dot on time, so I'll try to stick with time. So preserving the kidneys in the management of diabetes. Now, you see, while trying to prepare for this talk, I had gone through the KDOQI guidelines, which had come up 2020 with some modification in blood pressure in 2021, mainly the 2020 guideline. There are a few things which I have also learned from this, and a few sticky questions which always comes up in my mind. I will also ask it, and I'll also try and answer it. Okay, so the main problem is introduction. I've kept it very short. We know that CKD attributable to diabetes occurs in 20 to 40% of patients. Diabetic kidney disease occurs after around 10 years in type 1, but the situation is different in type 2. Some patients may present with diabetic kidney disease at the time of diagnosis of type 2, because of type 2 diabetes, you don't get to diagnose after about 4 to 5 years. So the two things which tells us that the patient has kidney disease, eGFR and the albumin creatinine ratio. How do you get eGFR? It's calculated from serum creatinine by a formula. You don't have to memorize the formula. Go onto the internet, download the app. All you need to know is the sex of the patient, age of the patient, and the creatinine value in milligrams or millimoles for that matter. These are only things that you have to input. You get an immediate eGFR. This is a must for every physician, every doctor. They should have it on their mobile phone. So an eGFR less than 60 is abnormal. More than 60 is not considered abnormal. As such, as far as the therapeutic intervention is concerned, less than 60 abnormal. Now, I've said about two things. One is eGFR. How did you get the eGFR? By seeing the creatinine level. Another one is urine albumin creatinine ratio. That's a one-off sample spot, small vial will do. It is not 24 hours. It is defined as a level less than 30 milligram per gram of creatinine. But remember, because of high biological variability, sometimes occurring in more than 20% between measurements in urine albumin excretion, you need at least two of three specimens collected within a 3 to 6 months patients before we say that this is clearly abnormal. However, in some cases, patients, we get very high albumin level. In that case, we don't have to wait for 3 to 6 months. But majority cases, it is not very high. So one reading, no, don't stamp it as as albuminuric. Wait for another 3 months, repeat it. If you get 2 readings out of 3, which is raised, then you stamp it. Because there are a few other reasons why the urine ACR might go up, which is exercise, infection, fever, heart failure, marked hypertension, marked hyperglycemia. So those may cause rise in urine ACR without actually damaging the kidney. So that will give you false high levels. So what are the ways we can screen and diagnose? So for screening and diagnosis, I've put all these three together. So this, I think we could have ignored the KDUQI 2007 and 2012, ADA 2021, KDIGO 2021. So ADA says diabetes, patients type 1 diabetes more than 5 years, and all patients with type 2 diabetes should be screened at least annually. And KDUQI said patients with diabetes, they've left to generalized patient diabetes should be screened. Initiation and frequency should be individualized. What do you screen with? eGFR and urine ACR. When do you say it's abnormal? eGFR less than 60 for more than 3 months, because sometimes there might be, and even when the creatinine might go down. So if the GFR is less than 60 for 3 months, then we stamp it as CKD. So GFR less than 60 and or urine ACR more than 30. So that's the same for the KDIGO. So I've given you the definitions of urine ACR and the variability of the urine ACR, definition of urine eGFR, and I've told you how frequently to monitor for screening and diagnosis. Now, why are these values important? Because you can see here the hazard ratio for mortality for urine ACR is very impressive, that after 30 really takes off. For eGFR, it does stay at 90 to 75, it does stay at 1, which is same as normal people. But after 75, so it really begins to take off around 60. So I think these cutoffs are not only important from the renal point of view, but they are also important for the cardiovascular mortality point of view, because it is beyond these cutoffs that the CV mortality begins to really pick up. Now, so I will, with each point where I think questions would be asked, I will ask that. If I was studying medicine, urine PCR. So this has always fascinated me, because many times I get urine PCR report And on one occasion I confused with the urine ACR because I didn't see the P here. So be very careful, because urine ACR and PCR is not the same, but you will get urine PCR reports occasionally. So what is PCR? It is protein creatinine ratio. Why is it done? So urine ACR is specific for albumin, but you may get leakage of other proteins of lower molecular size, like renal tubular disease or light chain disease, without actually seeing an increase in albumin. So you might miss them if you just do an urine ACR. So urine PCR, therefore, is used in lupus nephritis, hypertension, preeclampsia, and in many renal diseases of the children, where the tubules are affected. So their urine PCR might have a higher value, and often used as an alternative to urine ACR. But let me quickly add, before we jump into urine PCR, should we use urine PCR then for our diabetes patients? Answer is no, because urine ACR is a more sensitive and specific marker of glomerular damage, which is what occurs in diabetes. So urine ACR is more sensitive and specific for glomerular damage. Therefore, its use is most predictive. And recent clinical trials of cardiorenal treatment, all of it mentioned urine ACR. So that's the test of choice for measuring kidney damage and assessing CV risk. So I hope that puts to rest the question about whether we should be using urine PCR. So what are the values? So urine is, this is A1 is normal or mildly increased, A2 is moderately increased, and A3. You can see here, urine ACR, the one we use milligram per gram, less than 30, 30 to 300, and more than 300. And the corresponding PCR is 0.15, 0.15 to 0.5, and more than 0.5. Because I saw the report was 0.3, and I said, oh, it is normal, but it is not, because that is urine PCR. So please see the report carefully. Urine dipstick, if it's traced to 1+, that means it's moderate increase, and 1+ or greater, severe increase, but we don't use this routinely in our practice nowadays. So I've told you about screening, but when to think that, oh, hang on, this might not be due to diabetes. So an active urinary sediment, rapidly increasing albuminuria, very high albumin levels, albumin in the urine, rapidly decreasing EGFR, or in type 1 diabetes, absence of retinopathy. Let me repeat this again. For type 1 diabetes, if you do not have retinopathy, you have to question whether the nephropathy is due to diabetes or not. But not so for type 2 diabetes, because in type 2 diabetes, the presence or absence of retinopathy is not that sensitive a marker for renal disease. So it is rare for patients with type 1 diabetes to develop kidney disease without retinopathy. So if you have a type 1 diabetes, the absolutely clear eyes, but kidney problem, think there must be something else, refer. But type 2 diabetes, retinopathy is only moderately sensitive and specific for CKD. Okay? So if a type 2 diabetes patient doesn't have retinopathy, but has kidney disease, it is still, it could be due to diabetes. Don't jump into other causes. So these are the classifications. Now A1, A2, A3, and here is the GFR category G1 to G5. So you can see here G1 is more than 90, G2 862, 89, G3 and A and 3B 45 to 60 and 30 to 44. And this is the albuminuria category, less than 30, 30 to 300, more than 300. Now these are the box given in the ADA, and this is a very nice box really, because if you see here, it's written there are some values here. This means how often in a year, annually, should you be checking it. So if it falls here, say for example, somebody has EGFR more than 90 and urine ACR say 100, so you should check it annually. That's what this guideline says. Now 2 means you should check it every 6 months. 3 means you should check it every 4 months. 4 means you should check it every 3 months or more frequently. And refer means you should refer to the nephrologist. So these yellow bits, red bits, you have to remember are refer except 1. So this guideline is very clear, telling you how frequently to measure urine ACR and creatinine. and when to refer biochemically. And I've told you when to refer when you're thinking something else is happening. So two areas where the referral is needed. One, when you're suspecting this is not diabetic kidney disease, when to suspect, I've told you. Second, biochemically, creatinine and urine albumin creatinine ratio, the values will tell you when to begin to refer to the nephrologist. So diet. Now this is has become a controversial area actually, because I have grown up knowing that you have to have a lot of protein restriction for preventing CKD. If somebody is developing CKD, protein restriction is a must. But the volume of literature written is quite mind-boggling actually. But the KDI-GO and KDO-QI have come up with a one-line answer. They've said that protein intake of 0.8 gram per kilogram per day. That's it. You should avoid taking high protein intake more than 1.3 grams per kilogram per day. But you should have 0.8. That's a relief for majority of the patients and doctors, because otherwise we end up giving, reducing the protein like anything in the hope that it will improve. But KDO-QI says that the evidence that giving protein less than 0.8 improves GFR is not that compelling. So protein intake of 0.8. So it does not recommend it, and it does not alter glycemic measures, cardiovascular risk measures, or the course of GFR decline. So for patients on dialysis, you have to increase the levels of dietary protein intake, since malnutrition may be a major problem. And sodium less than 2.3 grams a day. That might be useful in controlling BP and reducing CV risk. So these interventions, particularly sodium, may be most important for patients with reduced eGFR, for whom urinary excretion of sodium and potassium may be impaired. So this is the classic, this is the typical plate. So half a plate should be fruits and vegetables. A quarter should be protein, animal or plant, preferably plant, and quarter should be whole grains or starchy vegetables. Okay, so that's how the diet should be. Previously, this bit was much smaller, but now at least it has occupied a quarter. So animal proteins and plant proteins, this gives a rough idea how much is there in each of them. So you have a meat, 28 grams, you get about 8 grams, one egg about 6 to 8 grams, but legumes, 100 grams is 7 to 10 grams, and a half cup of cooked whole grain cereal is about 3 to 8 grams protein, which is not that really that high. So for hemodialysis patients, it should be 1 to 1.2 grams per kilogram. So moderate lifestyle intervention, very important, moderate to intensive physical activity. Many patients think I've got kidney damage, so I should not do any exercise. No, that's wrong. Simple walking should be there for everybody, whether you have got nephropathy or not, even whether you have got neuropathy or not. Yes, if you have got severe autonomic neuropathy or if you have got foot ulcer, that's a different question. Okay, am I audible? Hello?
Yes.
Hello? Am I
Yes,
audible?
yes, you are audible.
Okay.
Audible.
Okay, so now this triangle tells us a little bit about the wholesome comprehensive care. So all the patients should have lipid management, blood pressure control, glycemic control, should do exercise, have proper diet, and stop smoking. Most patients should be on RAS blockade or SGLT2 inhibitors. And some patients should be on antiplatelet therapies. So I hope that really summarizes it, which I'm going to detail it out in a bit. So question about RAS blockade. So we recommend, this is the KDI-GO, that ACE or ARB should be initiated in patients with, it's important to read between the lines, diabetes, hypertension, and albuminuria. And these medications should be titrated to the highest approved dose, because most of the benefit has been shown to be with the highest dose, not just start with say Ramiptil 2.5 and forget. The benefit with the highest dose. Okay, so that's very important. Now, For patients with diabetes, albuminuria, and normal blood pressure, what to do? Should we start? Here they have said it may be considered. So remember that it not must. The language is different because the evidence is not that robust if there is normal blood pressure and diabetes albuminuria. So you may consider starting the ACE and ARB. So when you start ACE ARB, you check for creatinine 2 to 4 weeks of initiation. Hang on. What I have been told before is you have to check potassium and creatinine within 1 week. Why am I saying now 2 to 4 weeks? I'll come to that in a minute. If you continue it, unless serum creatinine rises by more than 30%, if the rise is more than 30% within 4 weeks, then you may think about stopping. Now, this is the algorithm when you're starting ACE inhibitor or ARB. KDIGO guideline has steered away from mentioning which one is better, ACE or ARB. They have always said ACE or ARB. And they have not singled out any drug, which drug is better than the other. Okay, so from this, I will not be able to answer the question whether to start ACE or ARB, but I will tell you my viewpoint as to why I would prefer one over the other and why. I'll give you the reason. So when you start ACE inhibitor ARB, you check creatinine and potassium within 2 to 4 weeks. If potassium is normal and the creatinine has not risen, continue. No, you increase it to the maximum dose. If the potassium is raised, don't stop. I will tell you why. You consider adding diuretics or sodium bicarbonate, reducing potassium in the diet. If there is more than 30% increase in creatinine, correct volume depression, NSAID, and review for causes of acute renal injury. Always they have written reduce dose or stop as last resort. So I'll come to this 30% creatinine. So why it is important? The rise in creatinine should not be a deterrent in stopping it. Why? Because in clinical trials, there is a suggestion that the greatest slowing of kidney disease occurs in patients with the lowest eGFR. And in a review of 12 RCTs, they have shown that kidney disease progression amongst patients with pre-existing kidney disease demonstrated a strong association between acute increase of serum creatinine up to 30% from baseline that stabilized within 2 months. So patients with CKD in whom the creatinine goes up but below 30% and settles after 2 months, they seem to show a better effect. So that should not stop us from giving the ARB. More than 30, yes. Less than 30% rise, no. Now potassium. So here, again, we are a bit afraid that, oh, potassium is high, we stop it. No. You see, this possibility, hyperkalemia, is a known complication and can occur in up to 10% of outpatients. So risk factors for the development of hyperkalemia include CKD, decompensated, just give me a second, decompensated CCF, volume depression, advanced age, use of concomitant medications. So there's a big list of conditions where the potassium might go up if you use ACE ARB. So this is actually the same group of patients who would get benefit from the ACE ARB. And that is what they are trying to say. This is the same population who would be expected to derive the greatest benefit. So therefore, think about using ways of correcting the potassium by adding diuretic, sodium bicarbonate, low potassium diet, and see that does the trick. But don't deprive them, because this group is the one which deserves ACE ARB. Now, this is the list of the ACE inhibitors and ARB. I personally favor ARB. Why? Now, one of the reasons is here. Now, you can look here from the ACE inhibitors, majority of them would need dose adjustment for if the creatinine level drops. But for the ARB, majority of them would not need dose adjustment, like say irbesartan, losartan, telmisartan. They don't need dose adjustment. Azilsartan, they don't need dose adjustment, creatinine goes down. But here, for them, it requires dose adjustment. Also, ACE inhibitor-induced cough occurs up to 10% of patients. If you change them to ARB, that should do the trick, although there's no RCT to say that how much of reduction there is. Also, angioedema, it occurs in about 0.3% of ACE inhibitors, but for ARB, it is not different from placebo. So glucose levels, so you have to it depends on the macrovascular complications, comorbidity, life expectancy. So lower the age, more the life expectancy, lower the HbA1c we should aim for. Elderly, more comorbidities, we should aim for a higher HbA1c. So the glycemic management should include lifestyle therapy and first-line treatment with metformin and SGLT2 inhibitor. So what they've said is, majority of the patients, you should use, of course, metformin is first, then SGLT2. So things have moved on. For metformin, if eGFR is more than 60 or more than 45, so you can use it all together. eGFR more than 45, start and go up to the maximum dose. eGFR less than 45, initiate at half the starting dose and go to half maximum. So that's a bit of a change. Previously it was 60, but now it is 45. For SGLT2 inhibitors, I note that I have only 5 minutes left. So I will hurry up 5 or 6, 7 minutes. The SGLT2 inhibitors, they cause afferent arteriolar vasoconstriction by increasing the sodium here, because there's more sodium in the tubules. That reduces the pressure in the glomerulus. That will reduce the eGFR by a small amount. But in the long term, there is less blood jamming the glomerulus, so you'll get less damage. So if you look at the cardiovascular and renal effects of SGLT2 and GLP-1 or the DPP-4, the albuminuria is good, best for SGLT2, but good for GLP-1 and DPP-4. But as a physician, I'm really after eGFR loss. So it arrests the progression of eGFR loss. GLP-1, one or dulaglutide does it, but the rest don't, and DPP-4 inhibitors doesn't stop the relentless march of the eGFR. So if you look at the SGLT2 inhibitors, end-stage renal disease, plus death due to kidney disease, plus cardiovascular death, all favor the SGLT2 inhibitors. But the important bit is this, that if you have stage 1 to 2 CKD, then also it has got benefit. If you have got stage 3 to 5 CKD, then also it has got benefit. Also, this is benefit as far as CKD progression is concerned. So if you look at the specific values, eGFR more than 90, then also there is benefit. 60 to 90, 45 to 60, less than 45, so at every stage of renal function, it helps. And at every stage of albuminuria, it helps, because many people think that, oh, there is no albuminuria, so SGLT inhibitor is unlikely to have that much of benefit. No, wrong. Urine ACR less than 30, then also look at the good benefit in preventing the relentless march of the eGFR. So these are most of the trials which looked at the utility of SGLT2 inhibitors in CVOT, heart failure, and CKD trials. And you can see here, previously the IDNT and renal trials with the ARBs, they occurred in patients with urine ACR quite high, credence and DAPA CKD, but we have got multiple SGLT2 inhibitors where they have used it in eGFR, which is normal, or urine ACR, which is normal. So therefore, if a patient has got CKD and on metformin, you should think about adding the SGLT2 inhibitor. If necessary, you should stop or reduce the dose of other anti-hyperglycemic drug, because the SGLT2 inhibitor will give you good benefit in preventing the relentless march of kidney disease. Okay, I'll just take another couple of minutes if chairperson allows. Remember, one common question is, once an SGLT2 inhibitor is initiated, you should continue. One common question asks, oh, if the eGFR now drops below 30, what should I do? No, you continue it, because it's not going to cause any incidence of acute kidney injury. In fact, the studies have shown, meta-analysis have shown, that incidence of AKI is actually less with the SGLT2 inhibitors. So if somebody's eGFR is 31, you start SGLT2 inhibitor, drops below 30. No, continue it. There's no need to stop it. If it is less than 30 to begin with, then you may not start. But if you have started it, don't stop. So the other agents are the GLP-1 receptor agonists. They have some benefit in progression of nephropathy, but I will hasten to add the whole benefit is due to albuminuria reduction, not preventing the progression of the kidney disease. But for the GLP-1 receptor agonists, majority of them, you don't need to adjust the dose based on the eGFR. Now, this is the effect on albuminuria and GFR loss. You can see all the SGLT2 inhibitors have done a great job by reducing both handsomely. With the GLP-1 receptor agonist, only dulaglutide reduced the effect on GFR loss, whereas all the others did for albuminuria only, not for the eGFR loss. So to summarize at the end, for diabetic patients with CKD or with CKD, for as far as glycemic control is concerned, you think about metformin plus SGLT2 inhibitor. That does not control the blood sugar. You need to add something else. Then you think about GLP-1 receptor agonist. After that, you think about the others. This circle, I think you should look at leisure because it tells us very nicely as to conditions and which drug would favor it. The last few slides, multi-pronged approach. So blood pressure, sugar, lifestyle change. So Steno 2 had told us that if you control the HbA1c, cholesterol, and the blood pressure, you get extremely good benefit in all the facets of macrovascular and microvascular complications. But there is a recent trial which had come up just a few months ago. This is an ID2 study which has done a similar thing of blood pressure less than 130/80, HbA1c 7, and control of the cholesterol in patients who have got already quite significant albuminuria, diabetic retinopathy, but no history of CV events. This is different from Steno, where they also had a history of CV in some of these patients. But this is primary, no history of CV events. Even in these patients, it showed that the MACE occurred in only 53% lower, and all-cause death was 47% lower. So here, the difference between Steno 2 and this recent study was that they had albuminuria, retinopathy, but no CV event group. So this is really a very nice example of a primary attack at multi-pronged approach. So this is the absolute last slide. I've talked about lifestyle intervention. I've told you about comprehensive management, which is blood pressure control, lipid control, glycemic control. I've told you about the glucose tablets, and I've told you which agents you would think. So I think with that I end. I'm sorry I exceeded by 2 minutes.
Thank you, Kulanda, for your wonderful deliberation as always. I think now the issue of preserving the renal function in a diabetic is solved. We have one question in hand which says, does microalbuminuria reduction lead to any hard-end renal points being reached in a diabetic patient? There are many anti-diabetic agents which show only reduction of albuminuria. Will using them lead to any reduction in achievement of the hard-end renal points?
So that's a very great question actually. So just reducing the albuminuria is not going to translate into reduction of cardiovascular endpoints, because the slides I've shown you, all the DPP4 inhibitors universally reduce the albuminuria, but they have not led to reduction in the eGFR, they have not stopped the eGFR drop. They have not caused any cardiovascular benefit. So it's only the SGLT2 inhibitor have reduced the albuminuria and had the renal benefit. And one of the GLP-1 receptor agonists reduced the albuminuria and had renal benefit. Many of the GLP-1 receptor agonists reduced the albuminuria and had CV benefit, but not renal, only one had. So it is reducing the albuminuria necessarily is not equal to reducing the mortality or the cardiovascular. In fact, if you look at the Cochrane analysis, just albuminuria reduction is not going to reduce your mortality or cardiovascular endpoints.
Thank you, Kulanda, and thank you for that wonderful session. And we are all grateful to you. And We are looking forward to hearing you again on Sunday. We would now, this session was supported by an educational grant from Lake Town Synergy, and we would have a look at what we went to Professor Nilanjan Sengupta. We'll have a look at what he had to say about the conference for just a brief moment before going on to Dr. Soumik Goswami, who would talk about the time in range saga that's going on nowadays in the range of diabetes. Dr. Soumik Goswami is a faculty DM endocrinology in the Department of Endocrinology in NRS Medical College, and is a erudite speaker and needs no introduction to this audience, perhaps. Let's hear Dr. Sengupta.
ENDIAB Summit will be organized by Lake Town Synergy to commemorate Charles Best, and I congratulate Dr. Soumyabrata Roy Choudhury and his vibrant team for drawing up a very interesting program that will cater to the scientific needs of consultant physicians, diabetologists, endocrinologists, students, and also, like every year, there will be a very interesting quiz in which pharmaceutical industry personnel will compete for the championship. So this is really a very interesting program on the cards, and I am very happy to be a part of this academic extravaganza, because I would be delivering a talk as a speaker. I wish this program all success.
Thank you, Nilanjana. And over to you, Dr. Soumik Goswami, please, for your session. Tackling the triune of hypoglycemia, variability with the Gen 2 basal insulin. Dr. Goswami is an assistant professor, Department of Endocrinology, and an associate editor, Indian Journal of Endocrinology and Metabolism, and has more than 50 publications in peer-reviewed journals. Dr. Goswami, the stage is all yours.
Thank you. Thank you, Dr. Roy Choudhury, for the kind introduction. Now, for those of you who are staring at my screen, and if you're wondering what does Triune, T-R-I-U-N-E, refer to, I was similarly left wondering a few days back when I was given this topic to speak on. But as usual, the good old internet came to my rescue, and when I searched for Triune, I found that Triune is actually a word which is of Christian origin. It's of biblical origin. It refers to the Holy Trinity of the Holy Father, Jesus, and the Holy Spirit. Now, if you're wondering what religion has got to do with science, because we'll be discussing science today, I too was left wondering, but actually they are poles apart, because we know that it was famously remarked that religion is the culture of doubt, while science, rather religion is the culture of faith, pardon me, while science is the culture of doubt. So this lack of faith actually by clinicians, by researchers, in the good old trinity of fasting, postprandial glucose and HbA1c actually led to the newer concept of including hypoglycemia, glycemic variability, and possibly time in range, so that we move from doubting the holy trinity of fasting PP, HbA1c to a new era where possibly we will include more parameters while monitoring and treating patients with diabetes. Now, to keep things simple, I'll first take you through the flow of the presentation, which is first I'll be dealing with the new triune, or the so-called new trinity, which has popped up in the management of diabetes. I'll be talking of their basics. I'll be briefly touching on what big global associations have to speak about this new trinity. I'll be then touching on how basal insulin therapy can be used to tackle this trinity, the new trinity, not the old one. And of course, I'll be ending by comparing the very latest basal insulins in terms of their effects on blood glucose control, particularly with reference to hypoglycemia and glucose variability. Now, as I said, glycemic variability is something which forms the cornerstone of the newer concept of management in type 2 diabetes and also possibly in type 1 diabetes. Now, what exactly is glycemic variability? Now, as the word denotes, it means the day-to-day and the within-day fluctuation from one point of time to another in blood glucose levels, which means that at one point of time, you might be having a blood glucose level of, say, 72, and at another point of time, you might be having a blood glucose level of 192. Now, this point-to-point fluctuation is what constitutes glycemic variability. And there are studies which have shown that independent of HbA1c, glycemic variability leads to more oxidative stress. And if the variability is on the lower side, if it goes on to the lower levels of blood glucose level, you automatically have what is called severe hypoglycemia. Now, again, as a clinician, we know that severe hypoglycemia is extremely bad, but most people recover from severe hypoglycemia. Oxidative stress sounds something serious, but what are the clinical implications actually? The clinical implications of glycemic variability are not merely theoretical, but much significant, because most importantly, it could lead to increased mortality. So even if it does not lead to increased mortality, more glycemic variability has a very strong association with cognitive impairment. So it could increase your risk of developing dementia. And of course, it also increases the risk of macrovascular complications. There is a big association between increased glycemic variability with markers of macrovascular disease and cardiovascular damage. Just to have a closer look again at what this glycemic variability and time in range is. If you look at the image on your screen to your right, you see two lines, a red line denoting a blood glucose level of, say, around 80 milligrams per deciliter, and a yellow line denoting a blood glucose level of, say, 140 milligrams per deciliter. Now, most of us would love our patients to maintain their blood glucose levels between this 80 to 140 milligrams per deciliter, because that means that the patient is neither experiencing hypoglycemia nor experiencing hyperglycemia. And that, simply put, is the concept of low glycemic variability and more time in range. If you look at the image to your left, you see three different patients, all of whom have a HbA1c of 7. Now, out of these three patients, there could be two patients who are also experiencing periods of hyperglycemia and experiencing periods of hypoglycemia. But we know that since HbA1c is the mean blood glucose level, the hypos and the hypers may neutralize each other out, and you get a perfectly good HbA1c. But the same individual might actually be experiencing bouts of hypoglycemia and might be having periods of postprandial hyperglycemia unknowingly, because when we do the HbA1c, merely get the average without looking at the peaks and the troughs. So to sort of get over this problem of merely looking at the HbA1c, a big expert committee was constituted. And this big expert committee, they gave their reports in 2019, which were published in Diabetes Care. And this committee, by the way, included experts, nearly 40 different experts from 20 different countries across the globe, who looked at all the available evidence and said that if you maintain a good time in range, and if you have diabetes with good time in range, the chances of developing complications go down, your quality of life improves, and the chance of developing hypoglycemia goes down. So what were their recommendations? They recommended that to do a time in range, or to get the time in range value, you needed to do a continuous glucose monitoring, or preferably an ambulatory glucose profile, which had 14 days worth of continuous glucose monitoring values. If you looked at the entire value, and more than 70% of them were within a range of 70 to 180 milligrams per deciliter, you were actually doing well. They also said that the time below range, that is less than 70 milligrams per deciliter, should be less than 5% of the total time during a day, and the lower the better. If it was 0, it was the best that could happen. The time above range again should not be more than 30% of all the values. Again, the lower the better. Simply put, it means that if most individuals spend most of their time within the 70 to 180 milligram per deciliter bracket, it means that they will have low glycemic variability, they will have a good HbA1c level, and naturally a marriage of good HbA1c and good glycemic variability reflected by a good time in range would possibly translate into a lower risk of complications. Now, we have been speaking of time in range over the last few minutes, but does it actually correlate with complications? If we look at the studies which have been published over the last decade or so, including studies which looked back at the DCCT trial again, it was found that a 10% derangement in the time in range, which means that as the time in range reduces by 10%, your risk of developing a variety of microvascular complications goes up significantly by anywhere between 25 to 64%. Now, what about macrovascular complications? There are several studies which have found that if your time in range goes down, you have an increased risk of having worsening of your carotid intima medial thickness. Now, again, honestly speaking, at this point of time, we do not actually have hard data that if you reduce the time in range, you are going to reduce the risk of microvascular or macrovascular complications. But logic dictates that if your time in range is good, you have good HbA1c levels and you have good glycemic variability as well, which in turn should of course translate into a lower risk of vascular complications. And as the saying goes, the lack of evidence for benefit is not the same as evidence for lack of benefit. So possibly we need bigger trials, newer trials, which use TIR as an active intervention to see if it reduces the risk of vascular complications. Now, at this point of time, TIR is something, or time in range is something which possibly some of us have started to use in our practice to some extent. But the scenario was entirely different, say around 10 years back. Now, this continuous glucose monitoring or ambulatory glucose profile is not something which has suddenly popped up. It was there from the early 2000s, but it was only in around 2012 that the first committee was formed, which looked at this time in range concept in a conclusive scientific manner. But it took 7 years before the expert committee, which I was speaking of, actually brought out the first concrete set of rules regarding time in range. Of course, there are other subgroups also, like pregnancy time in range, type 1 time in range, adolescent time in range, and I would not like to burden you with all those statistics. But simply put, the 2009 committee told us that if you maintained more than 70% time in range with less than 5% time below range, you were doing good enough to keep your patients healthy. Gradually, the big bodies, the ADA and the AAC, also started adopting this time in range concept. And if you go through their recent guidelines, they have included this concept in their guidelines as a tool, as a supplement to HbA1c, not replacing HbA1c, to improve your quality of life, to reduce the risk of hypoglycemia, and in certain subsets, improve glucose control. Now, having spoken about time in range, it's easier said than done. In our country, we have around 7.5 crore individuals with diagnosed diabetes. Leave aside those with undiagnosed diabetes. Doing an HbA1c itself is a challenge. Doing a time in range using an ambulatory glucose profile or a continuous glucose monitor would be almost impossible in the vast majority of our patients whom we see in our day-to-day practice. So how to deal with this time to range in range issue? An easier or more practical way of doing it is that you could do the monitoring once in a while in a certain patient, but for majority of your patients, it would be better to use drugs which actually have been shown to improve the time in range by reducing glycemic variability and improving HbA1c. Now, talking of these drugs, with the oral drugs, we have a lot of evidence with the DPP-4 inhibitors, with the alpha glucosidase inhibitors, that they help improve, reduce glycemic variability and help improve the time in range. But today, we'll be talking about insulins, and we'll be specifically talking about whether a basal insulin can help reduce the risk of hypoglycemia and improve the time in range. Basal insulin, because if you go across the guidelines, the ADA guideline or the ASA guideline, as of now, they say that if you are not controlled with oral anti-diabetic medications, the first insulin that you add is a basal insulin. Now, when we add a basal insulin, we know that the fasting plasma glucose is definitely going to come down. But what we also should recognize is that as the fasting plasma glucose comes down, the postprandial peaks start coming down as well, because the baseline has come down. As the postprandial peaks start coming down along with the fasting plasma glucose, to some extent, they reduce the glycemic variability. Now, speaking of the other part of glycemic variability, hypoglycemia and insulin, these two more or less seem to be synonymous. So how can you use a basal insulin with a lower risk of hypoglycemia to reduce glycemic variability or reduce the time below range? Again, we have data that when you are using a U100 glargine, you have a much lower risk of hypoglycemia compared to a NPH insulin. But we have gone beyond U100 glargine today, because we have modern insulins like U300 glargine and insulin degludec, which carry an even lower risk of hypoglycemia than U100 glargine. Now, when I spoke about initiating an insulin, the first insulin being a basal insulin across these guidelines, you could argue, why not begin with a premixed insulin or begin with a co-formulation like IDEC aspart? Now, if you look at studies which have initiated insulin in insulin-naive patients, they have shown that if you keep the oral drugs intact and initiate a long-acting basal insulin, you get similar glucose control compared to shifting the patient to twice daily premixed or once daily co-formulation. However, the risk of hypoglycemia when you're using a single basal insulin is much lower compared to initiating with a premixed insulin or initiating with a co-formulation. Initiating with basal insulin makes sense because you have a lower risk of hypoglycemia. And hypoglycemia, of course, is the biggest barrier in intensification of therapy in patients with diabetes. And we know today that severe hypoglycemia is an independent risk factor for cardiovascular disease and mortality. Hypoglycemia also carries some practical connotations. We know that initiating insulin is difficult. It's almost like climbing a mountain. You have to overcome a number of barriers and inertia. If initiating insulin is difficult, the next difficulty we often face is that patients stop insulin all of a sudden or reduce their dose drastically all of a sudden. And this is primarily because when you have initiated insulin and start up titrating insulin, patients experience hypoglycemia. So the aim of putting a patient on insulin is to get good glucose control. And unless your patient stays on insulin, remains compliant on insulin, your entire effort goes down the drain. So naturally, you would love initiating with an insulin which has a lower risk of hypoglycemia to begin with and a lower risk of hypoglycemia throughout. And if we look at the evolution of basal insulin over time, over the last 60 to 70 years, as we have newer basal insulins, it is not that they have greater efficacy when compared to the older basal insulins, but they definitely carry a lower risk of hypoglycemia compared to the older basal insulins. The two very latest basal insulins that we have today are insulin degludec and U300 glargine. And over the next 5 to 7 minutes, I'll be discussing the head-to-head studies between these two molecules. As I discussed a short while earlier, while you are initiating insulin, you're overcoming a big barrier, but the next big hurdle remains discontinuation or an abrupt dose reduction of insulin because of hypoglycemia. The BRIGHT study gives us a bright perspective in this direction. In this study, about 450 odd individuals were randomized to U300 insulin and 450 odd individuals were randomized to insulin degludec. Both these groups of individuals were insulin naive to begin with and had poor glucose control. During the first few weeks, the insulin dose was up titrated in a treat to target fashion, and it was maintained over the next 12 weeks. Now, in terms of efficacy, as with the older basal insulins as well, the latest two basal insulins were head-to-head, neck-to-neck similar in terms of glucose control. However, there was a difference in terms of the overall number of patients who experienced hypoglycemia and the number of episodes of hypoglycemia, with both these conditions being lower in the patients who were given U300 glargine compared to the patients who were initiated with degludec during the first 12 weeks where you had an up titration of insulin. And as we discussed, when you have initiated insulin and you're up titrating insulin, a hypoglycemia there can lead to discontinuation or abrupt dose reduction of insulin. It was not only overall hypoglycemia, but also nocturnal hypoglycemia. The number of episodes of nocturnal hypoglycemia during the titration phase was lower with U300 glargine compared to insulin degludec. If we just have a snapshot of the BRIGHT study, you get to see that a number of episodes of hypoglycemia were significantly lower with U300 glargine compared to injection degludec when you were up titrating after initiating insulin. As we discussed earlier, if you experience hypoglycemia here, you have a far worse outcome in terms of compliance compared to not experiencing a hypoglycemia immediately after initiating and up titrating insulin. Now, the BRIGHT study looked at hypoglycemia using the good old capillary blood glucose monitors. However, as we discussed, we have now moved to a new age of time in range. We have now moved to a new age where we can look at the blood glucose levels every 15 minutes or every 13 minutes using continuous glucose meters. And there are at least 3 different studies which have tried to more intricately examine the differences between U300 glargine and insulin degludec using continuous glucose monitoring. This was a study from Osaka in Japan, which took 30 patients with type 2 diabetes. All of them were given U300 glargine first, 5 days of continuous glucose monitoring done. They were then shifted to the same dose of insulin degludec, again 5 days of continuous glucose monitoring done. It was found that, again, in terms of time in range, they were more or less similar. However, in terms of time below range, in terms of hypoglycemia, the insulin degludec group was doing worse compared to the U300 glargine group. Simply put, it meant that if you looked at blood glucose levels more closely, instead of simply doing a capillary blood glucose monitoring, if you did it using a continuous glucose monitor, your risk of anytime hypoglycemia, nocturnal hypoglycemia, severe hypoglycemia was significantly lower with U300 glargine compared to insulin degludec. And as we discussed earlier, hypoglycemia remains the primary barrier for intensification of glycemic control, and severe hypoglycemia, of course, is directly related to adverse cardiovascular events and increased mortality. Another study, somewhat similar, it came from Japan, from Hiroshima in Japan. 12 patients were put on U300 glargine, 12 patients were put on insulin degludec. This time they used a flash glucose monitoring, 14 days data. The last 7 days data was looked into. Here again, the overall glucose control was similar in terms of the time in range being similar. However, nocturnal hypoglycemia in this second study was significantly lower with U300 glargine compared to insulin degludec. So 2 different studies, both from Japan, slightly different methodology. Both of them found lower hypoglycemia when you did a continuous glucose monitoring with the use of insulin U300 glargine compared to the use of insulin degludec. A third study, this time a real world study, not a randomized controlled trial, or not a trial done in a research setting. Here, patients were taken who had type 1 diabetes. Now, we know that type 1 diabetes is a somewhat different population because there's almost no baseline insulin to begin with. So you get to see the effect of these insulins more closely. About 104 patients were switched from an older basal insulin to U300 glargine, and 95 patients were switched from an older basal insulin to insulin degludec. It was found that overall glucose control, the overall risk of hypoglycemia was similar between U300 glargine and insulin degludec in type 1 diabetes patients. However, the nocturnal time in range was better with U300 glargine compared to insulin degludec, which was driven not by a decrease in hypoglycemia, but rather by a reduction in the time above range here. So in type 1 diabetes, the data suggests that you actually might get somewhat better glucose control over a period of time with the use of U300 glargine. We have a bigger study coming up, including more patients, including data collection for 20 days worth of continuous glucose monitoring, but we'll discuss this study later when the results are finally out. As of now, to sum up what we know about this newer trinity of glycemic variability, time in range of hypoglycemia, we know that glycemic variability is strongly associated with macrovascular as well as microvascular events. We know that time in range is strongly associated with microvascular complications and has strong correlations with cardiovascular surrogates. Time in range, if you look at it from a scientific point of view, is a marriage of good HbA1c and good glycemic variability. So if you take care of time in range, you have a good HbA1c level and a low glycemic variability as well. As of now, as I said, we do not have studies which have shown a decrease in time in range, translates into improvement of vascular complications, but logic dictates that a good time in range would be possibly the holy grail of good glucose management with the data that we have now. When it comes to improving time in range, doing a time in range in all of our patients with diabetes is something which is impossible because of logistic reasons. It is easier to use a drug which is known to improve time in range. When you have to initiate an insulin, it's a basal insulin which should be initiated as per guidelines and as per available evidence. Amongst the basal insulin, the newer basal insulins, insulin degludec and U300 glargine, carry a lower risk of hypoglycemia compared to the older basal insulins. If you compare these two head to head, the BRIGHT study showed that during the initial up-titration phase, you have a lower risk of hypoglycemia with U300 glargine compared to degludec. And a closer look at glucose levels using continuous glucose monitoring data has more or less, I think, now shown with good conclusiveness that U300 glargine carries a significantly lower risk of overall and nocturnal hypoglycemia compared to insulin degludec in patients with type 2 diabetes. So I began with the saying that religion is a culture of doubt, while science is a culture of faith. As scientists, we should learn to doubt, we should learn to question what is convention to help our patients stay better. But as of now, I think it's beyond doubt that possibly the best basal insulin that we have to improve time in range in our patients with diabetes is U300 glargine if we look at the overall evidence. Thank you, and I'll take up any questions if they are there to be dealt with.
Thank you, Soumik. Thank you for your wonderful talk. There are just a couple of questions, quick questions. Number one, what do we do to sulfonylurea when you are starting on a basal insulin? Do you reduce the dose? Do you
It's a
continue?
very, very important question. I think you keep the sulfonylurea on when you are starting a basal insulin, because there are many people who say I've started a basal insulin and the glucose levels have gone already. So you keep the sulfonylurea on board. Say you give it before breakfast, you give a basal insulin during the evening or at bedtime, or if you're using the ultra long acting U300 or insulin degludec, you can even dose them in the morning or any time during the day. You keep the sulfonylurea on only when you have to intensify to a say basal plus regime or a basal bolus regime or a premixed twice daily regime. You then take the sulfonylurea off. So you stick to the so-called basal once and daytime sulfonylurea regime.
Okay. Second question is, what about pioglitazone with basal insulin? What do you do with it?
So I think pioglitazone with any insulin, that should be the question. So if you look at the guidelines, again, I won't say what I feel. If you look at the guidelines, they say that in patients who require a very high dose of insulin, you can consider the use of pioglitazone, keeping in mind the fact that when you're using pioglitazone with insulin, you should expect greater weight gain and a greater risk of fluid retention and subsequent edema and possibly increased risk of heart failure as well. So it's a double-edged sword. In some patients, I do use pioglitazone with insulin if there's no, say, contraindication to the use of pioglitazone, or whom I can monitor closely to look for fluid retention and chances of incipient heart failure. So in difficult to manage cases who are requiring a very high dose of insulin, the guidelines say that you can add pioglitazone. Of course, with good monitoring.
Last quick question before I move on to the next session. One of our delegates has asked whether one of our delegates has asked a very, very important question. A 7-point glucose profile, can it point towards, maybe it's a cheaper option rather than the AGP or anything? Can it give us any data regarding, can it be of any help with regards to TIR?
Why not? Because with AGP, we are doing a 96-point glucose profile. So the more the better, the more the merrier, but 7 is better than 2 or none. So multiple points.
At least we can pick up the postprandial peaks.
Give you an idea, huh? We'll definitely give you an idea.
At least we can pick up the postprandial
we can do a 3 a.m. and pick up some nocturnal hypoglycemia as well. So yes.
Okay. Thank you, Soumik. Thank you for your presence, and our heartiest congratulations for this wonderful deliberation. Thank you for your time. As we move on to the next session, I can see Riddhish has already joined. The next session shows empowering holistic patient-centric care in type 2 diabetes, risk factor control and organ protection with SGLT2 inhibitors. The speaker is Dr. Riddhish Narayan Chakraborty, who is a DM and a consultant endocrinology at Narayana Super Specialty and Multi-Specialty Hospitals, Howrah, Rabindranath Tagore International Institute of Cardiac Sciences, AMRI, and Medica Super Specialty Hospitals, Kolkata. So as you can see that Dr. Riddhish is on both sides of the Ganges. Former Assistant Professor, Department of Medicine, Calcutta Medical College, several gold medals in MBBS, gold medal in MD Medicine, a proficient speaker in different conferences and scientific forums, and with numerous publications. And we all are awaiting the talk by Dr. Riddhish Narayan, where he will be talking about empowering holistic patient-centric care in type 2 diabetes, risk factor control, and organ protection with SGLT2 inhibitor. Over to you.
Thank you, Dr. Rachuri. I think I am audible.
Yeah.
Yeah. Yeah. So my dress is a little bit odd than any one of you because I'm about 3,000 feet above sea level. So it's really cold out here. So from there, I'm joining you. And with your permission, I would be wanting to share my slides.
Yeah, you can.
So very good evening to everybody. And at the very beginning, I would put a thank you slide. This thank you slide is actually for the organizers who have thought that I would be doing justice to this topic, and also the sponsors who have given this half an hour to talk on this particular topic. Now, the disclaimer that would be showing is that medical science is an ever-changing field. So whatever I am mentioning today is valid for the evening of 11th of February, and one fine morning, everything may change. So we will stick to that particular disclaimer. Now, I would begin the presentation with a hypothetical situation where, say, Mr. X, a 15-year-old diabetic on drugs A and drug B, has an HbA1c about 6.8. So are we happy with this lovable HbA1c? Probably we have to think about the CV risk burden, probably we have to talk about the renal risk burden, and probably the mortality issues have also to be discussed. Mortality risk burden and also to be discussed. So diabetes management has now shifted from an A1C or glucose-centric approach to an all-encompassing one, or a package. So concept of diabetes management is changing. A paradigm shift has occurred from the issue of CV safety to CV benefit. So initially, when we used to prescribe a drug to our patients, we would be more defensive in saying that, well, what I'm giving you will not do any harm to your heart. But now we are being more proactive from the defensive approach and saying, well, what we are giving is actually a benefit or collateral benefit which you are getting in addition to the glucose control. So the provider is sending out something to the receiver where the benefits are getting magnified. Now things are even better, that from CV benefit, we are now talking of CRM benefit, that is cardio, renal, and metabolic benefit. So you would dissect this C, R, and M gradually in the next 20 minutes. If we, because I'm a practicing endocrinologist, so my first concern would be obviously how it, the molecules, the SGLT2 class of molecules, and especially empagliflozin here, does regarding metabolic outcomes. So we know that the HbA1c reduction is quite modest. If you go across the studies, we see it is to the tune of 0.7 to 0.8%. Obviously, there are different studies. So when we are comparing apples with oranges, we should be dealing with caution. But still, we would say that the HbA1c reduction is quite modest with this class of molecules. Along with that, the collateral benefits that I was mentioning is obviously a weight reduction. Initially, those patients who are overweight, some patients actually perform very well, while some patients who are actually in the good BMI range, normal BMI range, can actually become thinner, and they often complain to us, doctor, we are losing too much weight, and as if I am now sick with some other disease, as people tell me. So weight reduction happens to different extents in different individuals. That is the experience. Along with that, there is reduction in blood pressure as well, though this may be a little bit less. The cardiologist friend often say that it's only a single digit reduction, but still whatever reduction happens is actually beneficial. This is because let us consider a scenario where a particular patient is getting 3 drugs from my side, 4 drugs from the cardiologist side. There at least 3 drugs are actually antihypertensive molecules. And when this drug is introduced, the SGLT2 class of molecules, and here if we talk of empagliflozin, even if there is a small reduction in blood pressure, that actually helps to down titrate certain antihypertensive medications. In some cases, obviously in hot summer months, diuretics have to be reduced. So if a person can be weaned off one drug, say he was getting 4 antihypertensive drugs, now you give this SGLT2 inhibitor, now he can do one drug can be withdrawn. That itself reduces the pill burden, and this obviously can be seen as a benefit. So summarily, the HbA1c reduction, the body weight reduction, and the blood pressure reduction are definitely on a solid footing. We see from the various studies of the SGLT2 class of molecules. Now, just a small mention about the post hoc analysis of EMPA-REG outcome, which was the first study which came out on this class of drugs. EMPA showed the reduce the need for insulin initiation in insulin-naive patients with type 2 diabetes and CV disease. And if you look at those patients who are insulin treated with type 2 diabetes and cardiovascular disease, in those patients, EMPA reduced the need for insulin dosage. So when we are giving this molecule, in some patients, maybe insulin requirement is coming down, and in some, maybe we are postponing the initiation of insulin. But there is a small caveat that I need to mention, that the take-home message from these two slides should not be that EMPA or any other SGLT2 inhibitor can be a replacement for insulin. Where insulin is required, it has to be given, because we know that there are situations where we have seen, though very small amounts, that there is a small potential chance of euglycemic decay. So in those circumstances where they're hugely insulin dependent type 2 diabetic patients where this drug is used, if insulin is down titrated too much and if the patient is put off totally insulin, so that may be a problem for that patient. Now, the various studies that came up in the last 7 years are worth mentioning, that there were different classes of studies, like some CVOTs were there, which included patients with type 2 diabetes and CVD or CV risk factors, like we had the DECLARE-TIMI study, we had the other studies like CANVAS program and EMPA-REG, etc. And there were studies then which were conducted, which were primarily cardio-renal trial, including patients with all of whom were type 2 diabetic and had CKD, like we can say the CREDENCE trials. Then were studies where some patients were diabetic, some were non-diabetic. So both type of patients were recruited in those studies, and they are kidney outcome trials. So in that group, obviously the DAPA-CKD is coming, and we would be keeping our fingers crossed about the EMPA kidney study as well. And we had trials where there were dedicated heart failure outcome trials in patients who had type 2 diabetes as well as those without type 2 diabetes. So different combinations of trials had been conducted, and we have varied results from coming out of them. Now, talking of the various class members of the SGLT2 class, we primarily use the empagliflozin, the dapagliflozin, and the canagliflozin here. Now, just as the children in a family are born out of two biological parents, but still they will have share some common features, there will be some commonalities, but they will also be different amongst themselves. So there will be some commonalities and there will be some differences. So in SGLT2 class also, we will have some where there are class effects, and there will be some which will have some specific effects, which we have come out in the various trials. Now, if you look at the how the SGLT2 inhibitors were associated with a reduced risk of 3-point MACE in patients with type 2 diabetes and either CVD or high CV risk factors, you see in the various trials, except the DECLARE-TIMI where the upper range of confidence interval had crossed the digit of unity, other trials definitely had favored the use of that particular drug in the study. If we look at the reduction of CV death, obviously only empagliflozin showed changes that it was found to be beneficial, where others, this particular point was not coming out in the studies. Now, SGLT2 inhibitors showed a consistent reduction in the risk of hospitalization for heart failure. Now, this actually is a class effect. Even in the Bhartia trial, which this drug we are not using, but even in that, there was a tendency towards improvement. So this particular feature, that reduction of hospitalization for heart failure, is present across the members of this class of agents. Now, if you look at the studies where we can see that empagliflozin reduced the heart failure outcomes, all-cause admission to hospital, all-cause mortality, and CV death in patients with type 2 diabetes and CVD. Here we can obviously see how the cerebrovascular outcomes and the heart failure outcomes are coming out in these particular studies. Now, EMPA reduced all-cause admission to hospital in patients with type 2 diabetes and CVD. And in the CVOTs, SGLT2 inhibitors reduce the risk of composite kidney outcomes in patients with type 2 diabetes and other CVD or high CV risk. So we were talking of the metabolic benefits, which we said regarding blood pressure reduction, glucose reduction, weight reduction, and then we are talking about the heart failure aspects as well as the CV mortality risk reduction. Then we also will be talking about the kidney aspect, which obviously must have been covered by one of my previous speakers, but we'll just touch upon that subject. Now, coming to a particular point, that whether SGLT2 inhibitors cause a decline or stabilization of EGFR over a period of time. Now, due to the peculiar mode of action of this drug, when we initiate this molecule, initially there is a dip in the EGFR because the glomerular hyperfiltration hypertension comes down, and at that phase there will be a little bit drop in EGFR, but then it will stabilize over a period of time. So this part is important, that after initiation there actually may be a little bit of drop, but that should not be a catastrophic drop. So that part has to be assessed when the patient has been started on this molecule. And if we see that again the EGFR is normalizing, then we can continue with this particular drug. Now, consistent reductions in CV, heart failure, and kidney outcomes were observed with the SGLT2 inhibitors in patients with type 2 diabetes and either CVD or high CV risk. We can see that all these programs or these studies had different benchmarks, different baselines. So obviously all did not have the same outcomes. So comparison has to be done with caution. Now, evidence beyond CVOTs has shown that the beneficial effects of SGLT2 inhibitors were also observed in patients with HFrEF or CKD. So we usually send our patients to our cardiologist friends regarding use, and now this class of molecules, because its overwhelming effect on the various aspects of heart failure, and especially for empagliflozin, we see it for reduced ejection fraction as well as preserved ejection fraction. This class of drugs has become a very favorite one for the cardiologists, and they use it quite rampantly. The effects of EMPA and dapagliflozin on the primary composite of hospitalization for heart failure or CV death in patients with HFrEF were consistent regardless of the type 2 diabetes status at baseline. So though this class of molecules actually emanated from an endocrinology lab, ultimately its fragrance was so mesmerizing that now even the cardiologists and the nephrologists can claim that is their drug, because they are showing benefits in their departments as well. So even the patient not having diabetes are showing good effects as far as these effects are concerned. And that is exactly why this class of molecules are gaining use, and even guidelines are approving their use in non-diabetic patients as well. In Emperor Reduced trial, the empagliflozin slowed the decline in the EGFR in patients with HFrEF with and without type 2 diabetes. So similarly, there will be initial notch because of the initial reduction in the EGFR, but ultimately it will stabilize over a period of time. And this slide shows that this happens also in patients who are non-diabetic. So this initial EGFR slide, just as we see in some patients on ACB, ARB as well, that there is a stabilization and ultimate improvement in EGFR. Now, how these beneficial effects are brought about and how they occur so much early after initiation is a matter of intense debate. There are so many putative potential mechanisms, like there may be diuresis, glucose excretion, because we know that this class of drugs actually cause therapeutic or pharmacological glucosuria. So these may be some of the reasons. The intermediate effects may be the change at the level of the myocardiums, whether they are shifting the metabolism from a glucose-centric one to a ketone-centric one, and whether this controlled ketonemia is actually improving myocardial function. This is obviously a strong mechanism which is put forward. The downstream observed effects are definitely, as we mentioned, there is a reduction in blood pressure, body weight, and HbA1c because it is a anti-hyperglycemic drug, reduction in CV events, and obviously kidney disease. Now, CKD has many facets. We know that lowering of EGFR is one aspect and proteinuria is one aspect. So it is a two-headed monster. What we need to mention is that an entire generation has gone by with no new treatments to effectively stem the rising tide of kidney failure in people with diabetes. And many nephrologists and endocrinologists have spent a good part of the last 25 years hoping that strategies other than AC and ARB can reduce albuminuria might similarly attenuate EGFR decline. So if you see, other than ACBRBs, not much drugs have been able to make a dent in this field. But let us see how SGLT2 inhibitors fare regarding the renal outcomes. Now, we must mention here that apart from SGLT2 inhibitors, GLP-1, some GLP-1 receptor agonists also have good responses as far as renal outcomes are concerned, but that is beyond the scope of today's discussion, so we are skipping that. Now, in the renal subgroup analysis of EMPA-REG, we saw that empagliflozin reduced the renal endpoint by 46%. Even in the DECLARE-TIMI trial, where the secondary efficacy outcomes were assessed, the dapagliflozin reduced adverse renal outcomes by about 24%. So signals were quite encouraging that they have some salutary role at the level of the kidney. And CREDENCE trial was done in a specific fashion, that this was a renal outcome driven trial, that the primary objective was to see actually that in type 2 diabetic proteinuric patients, what happens. So their albuminuria was reduction was seen, and primary renal outcome was reduced by 30%. So if you look at the summary of the various molecules, the studies, what we see that the three molecules, the Cana, Depa, and empagliflozin, in the three initial studies, those actually recruited population where the EGFR was quite in the relatively higher zone, like in the 60 to 90 zone, as we can see pointed out in the blue zone. But credence was definitely done in a much lower area where albuminuria was higher and EGFR was lower. Then we can talk about the DAPA CKD trial, where the primary composite outcome was noted, and there was a 39% relative risk reduction. And the exploratory renal composite outcomes were also quite encouraging. And in the subgroup analysis, we saw that the primary outcome by diabetic status and non-diabetic status, that also was quite encouraging, that the hazard ratio was quite encouraging in both the subclasses. And similarly, as we mentioned in empagliflozin, here also the EGFR decline was stabilized over a period of time. Now, whether fasting plasma glucose, PP glucose, and HbA1c are sufficient, as has been covered by some previous speakers about the time in range concept also, we know that HbA1c only gives an idea of the average value. Just like two students who are bosom friends in a class have secured the same marks in the final examination. But if you go through their mark sheets, you see that one candidate has done uniformly well in all subjects, while for the other student, he has done exceptionally well in some and has just creeped through or got the passing marks in some. So which of the students would gain your attention more? Obviously that who has done consistently well in all subjects. Similar is the concept of glycemic variability, that HbA1c may be equal in two patients. In one, the swings may not be more. In one, the swings may be more. But apparently HbA1c will not be able to delve deeper into these aspects. And because glycemic variability is so much important in today's timing, that we know that increased glycemic variability can lead to oxidative stress and vascular complications. So we have just mentioned a slide about what happens when you introduce SGLT2 inhibitions, and a 24-hour CGM with empagliflozin plus placebo in type 2 diabetes was assessed. And what we saw from baseline to day 1 and day 28, that the green zone, that is obviously the time in range, which is specified between 70 to 180, which should remain between 16 to 17 hours per day, that has been improved, while the red zone, that is the hyperglycemic zone, has actually shrunken. And obviously this class of molecule does not cause hypoglycemia, so the TBR, or the time below range, is not shown up here. Now, only thing when we talk good about any molecule, anytime when we are actually talking that, well, this is so good about this molecule, we should always take into account the realities or the differences between real life and the real life. So we have to watch out for some adverse events. So I have to select the patients quite judiciously. So every rose will definitely have its thorn, but that does not actually stop us from falling in love, especially when Valentine's Day is only 3 days apart. So we have to keep in mind about the urinary and genital infections, whether they are occurring in a particular patient. We should tune them about what are the symptoms, what they may appear with, so that they can rush to the doctor as soon as they occur. So urinary tract infection, genital mycotic infections, and in hot, humid climate like ours, the volume-related adverse effects like hypertension, dizziness, these aspects have to be kept in mind. Now, regarding the fracture issues, then amputations, these issues, these fears were raised earlier, but now this is not so much important. But regarding euglycemic decay, we have to keep in mind that in very insulinopenic patients, if we reduce the insulin, this class of molecules can potentially cause this, though this is exceptionally rare. So where actually we should not use a molecule should be more important than where we are actually starting it. So in some patients where the patient is in acute illness, or patient has just gone into the ICU or has just come out of the ICU, where the metabolic milieu is not yet stabilized, so homeostasis is not in proper stage. In those circumstances, the patient is in hypoxia. In those circumstances, we should actually not start this molecule. And even if they were continuing, we should be withdrawing for a moment so that the metabolic milieu stabilizes, and then we can reintroduce the molecule. Now, the proof of the pudding definitely lies in the eating, and whatever scientific evidence have come up are actually being incorporated into guidelines. So I remember this slide, which was we used to present when I was doing my DM residency, that after lifestyle modification and metformin, we could have chosen any of the 6 classes of drugs without any preference, bias, etc. But now, how things have changed, that we are going to an era of precision medicine, that after metformin or lifestyle modification, we will actually think whether the patient has predominance of ASCVD, predominance of CKD, whether there is risk of heart failure, or the patient initially had heart failure, whether there is need for reducing hypoglycemia. So all these aspects have to be taken into account, and then we have to choose the molecule. And if you look how SGLT2 inhibitors have now come up this ladder, and we can see them prominently in this chart, that in these circumstances, on the background of ASCVD, heart failure, CKD, need to reduce hypoglycemia, we can actually use this molecule with conviction. And can metformin be superseded? So this was almost impossible to think, or rather it was an audacious statement before 2019, before the ESC, ASD guidelines, where they actually mentioned that in treatment naive patients, type 2 diabetic patients, if there is a high signal of ACVD or target organ damage or multiple risk factors, you can actually gallop the metformin step and can start with GLP-1 receptor agonist or an SGLT2 inhibitor. So this definitely is a revolution in the flowchart or the algorithm of diabetes management over the period of time. Even in the kidney guidelines, you can see that how SGLT2 inhibitors have occupied a prominent position. Even in the 2020 ASN decision algorithm, we can find them. And also in the KDIGO treatment algorithm, we find that SGLT2 inhibitor, obviously, if the EGFR has fallen below 30, it is a contraindication. If the patient is on dialysis, it's a contraindication. But in other circumstances, in between the range of 30 to 60, 60 to 90, obviously, this is a golden phase where we can actually retrieve or retard the slide along the slope of kidney disease. In those circumstances, maybe SGLT2 inhibitors can come to a help to an endocrinologist or a nephrologist. In ESC 2019 guidelines, we saw that treatment with SGLT2 inhibitor is associated with a lower risk of renal endpoints and is recommended in EGFR is between 30 to 90. So there has been a widening of the spectrum. There has been an expansion in the horizon. This is how this looks. And Flozins has become almost everybody's darling now. Even you see nephrologists prescribing them, cardiologists prescribing them, obviously endocrinologists from where the use has started. So this is ultimately for the benefit of humanity, but obviously we have to keep in mind the precautions, the contraindications where we should not actually be using this drug. So conclusion will be that type 2 diabetes care requires an early, patient-centered, multifactorial approach aimed at risk factor control in the short term and leading to organ protection in the long term. And use of SGLT2 inhibitors with type 2 diabetes addresses key risk factors of the HbA1c, the time in range, the adiposity, the blood pressure, and the inflammation. And in patients with type 2 diabetes and high CV risk, SGLT2 inhibitors may lower the risk of CV events, reduce the risk of heart failure and kidney events, and stabilize the kidney function over a period of time. And there are secondary benefits on insulin resistance associated diseases, like there are some signals from ELIF study was done, though it is a small study on issues of NAFLD. There were studies on OSA, PCOS, etc. Then they are showing promising results, but this has to be corroborated with further trials. And SGLT2 inhibitors have once daily dosing, low risk of hypoglycemia, as well as manageable risk profile with optimum patient selection and counseling. So I end with the famous quote of Elon Musk that some people don't like change, but you need to embrace the change if the alternative is a disaster. So when you are talking of diabetes management, it is not only that you are managing the sugars, you have to take into account all those aspects which might bother the patient maybe 10 years down the line. So whether you are actually able to prevent the downslide of the organs should definitely come into your mind. And if the patient fits into that profile, we can start this molecule early. We end with a social message that on the 10th of March, in a couple of weeks, we will be celebrating World Kidney Day. Oh, definitely we should take good care of the kidneys of our patients as well when we are seeing their blood sugars. And wish you all a very happy Holi in advance. Thank you.
Riddish, are you there?
Yes, sir.
Yeah. Thank you for spreading the message of ENDIAB summit to 3,000 feet above the sea level. First, congratulations for that.
Thank you, sir.
And 3 rapid fire questions. We are just 2 minutes behind time. One, do you feel that all SGLT2 inhibitors are the same? Because some of them have data in primary prevention population, others do not have. Would you be tempted to use anyone in the primary prevention population?
And just as I said that there are some commonalities and differences. Some features are obviously across all groups like hospitalization for heart failure, the cardiac aspect. Now we see some signals for renal aspects as well. So when we are selecting a particular drug, maybe we can go with one molecule, but the doses like in EMPA, the doses will be at 10 and DAPA, it will be for 10 milligram. We can actually use for renal endpoints as well as cardiac endpoints.
Second, hospitalization heart failure prevention has been a common factor with all SGLT2 inhibitors. But again, in your talk, sir, you have said that do not use in very ill and sick patients, but very commonly we see it is being prescribed in the ICUs, even post-MI, etc. Do you feel that that's the way to go about
As
it?
an endocrinologist, I'm a little bit conservative in this zone. I might differ from my cardiologists and other friends who are using it. But when the metabolic milieu is not actually stabilized and the patient's EGFR is fluctuating, the patient might have suffered an AKI or has just come out of COVID infection or any reason for that in an ICU, I prefer to delay this initiation by about 7 days, because delaying 7 days will not be a big problem. Rather, if I initiate and there is an EGFR drop again because of this particular drug, it will only add to the problem. So as an endocrinologist, I'm a little bit skeptical about use in the acute phases of any disease.
Thank you, Riddish. You have basically echoed what our fraternity always says, that yes, you use SGLT2, but after you have stabilized the patient. Thank you for your time and for your wonderful presentation and the pictures and cartoons as always. I remember you pulling the leg of one of your colleagues by putting out from the Facebook the pictures of his childhood. So
thank you, sir.
Thank you so very much. And we are just in time. I would like to announce the finalist of tomorrow's Santosh Rastogi Memorial Quiz. BI Jardians has come first in the prelims with 18 points. Novo GLP team has come second with 16 points. Sanofi Insulin close third with 15 points. Novo Insulin fourth with 14 points, and Sun Arian 12 with Sun Arian, the fifth team, with 12 points. Please contact Mr. Dipan Shaha, get the link and be there at 4:30 p.m. And we will be back to the session after a very small video. From the very first day of our journey of Charles Best Memorial Day, from Yuva Bharatikirandan, we had received unrelenting support in the form of Santosh Rastogi. Not only us, everybody in the field of diabetes perhaps have had a hint of his presence and support for everyone, irrespective of name, stature, anyone in need. Our dear Santosh was there. And unfortunately, we have lost him in our war against COVID, a loss that can never be repaired by any newcomer, perhaps. From this year onwards, the pharma industry quiz, which was a big part of this event, a USP, so to say, of this event, is being named after Santosh as Santosh Rastogi Memorial Quiz. We also fondly remember the likes of Nirupam, Chinmoy, Shobhon, and many anonymous colleagues from the pharma industry who have lost their lives in our fight against COVID. May their souls rest in peace. So back to the session proper, and we will be looking at Dr. Sunil Kota. his topic is innovation journey. This is a GLP session consisting of 3 talks, each of 20 minutes. Innovation journey of the first and only peptide in a pill from lab to life. Speaker is our guest, Dr. Sunil Kota. He's a consultant endocrinologist, Diabetes and Endocrine Clinic, Orissa, faculty for certificate courses of CCE, BDM, CCM, TD, CCD, GM, and PHFI courses, co-investigator in several clinical trials, invited author and reviewer for various index journals, 85 peer-reviewed articles, and authored 18 book chapters. He's a member of all the international bodies relevant to endocrinology and an invited faculty at various regional and national conferences, recipient of Scope Scholarship to attend World Obesity Congress, Mexico, 26 September 2019. We welcome Dr. Sunil Kota for his deliberation. Welcome, sir. Thank you for being here.
Thank you so much, sir, for this very kind words. Yes, we have been moving ahead, and our quest for something new is not stopping anywhere. So the first time we are coming across a molecule where the peptide is in a pill. So I would be talking how it got from lab to life. So this would be my agenda, to talk to you about quest for ideal anti-diabetic drug, the pioneer study, which is basically highlighted this particular molecule and the quest to put peptide in a pill, and then I would be summarizing my presentation. In quest, why do we exactly are in need of newer drugs despite our armamentarium getting fuller by the day? Because we need to maintain the tightrope walk between the hypoglycemia and off-target effects, and then weight gain and the desire to lower blood glucose. So once you A1C is around 7%, our expectation from newer anti-diabetic drugs is that not only we wanted to control the sugars, but it should also protect our heart, our kidneys, should be not associated with weight gain. And if there is additional bonanza of weight loss, that would be again coming in handy. And in quest for anti-diabetic drugs, you look at all the parameters. You compare the different drugs that we have been using, the sulfonylurea, the thiazolidines, AGIs, DPP4 inhibitor, gliptin, GLP-1 receptor agonist, and insulin. So look at the efficacy point. GLP-1 receptor agonist is high, hypoglycemia risk it is low, weight, there is a reduction and there is a cardiovascular benefit. And apart from that, look at the physiological actions. The number of paths it is actually acting upon, it is increasing insulin secretion, decreasing glucagon secretion, slowing the gastric emptying, and also increasing the satiety. So it again stands out as one of the tallest molecules that we have in our disposal. And the myriads of effects addressing 6 out of 8 octet mechanisms by the defronzo. It acts on the liver, it acts on the heart and vessels, it acts on the brain, pancreas, GI tract, kidney, muscles. So out of these, we have 6 parameters which are being addressed properly by this GLP-1 molecule. But then the GLP-1 receptor agonists vary in the molecular structure and size. We have exendin-based therapy, that is exenatide and lixisenatide. These are short-acting molecules which are ideally better placed to target the postprandial hyperglycemia. Then we have the exenatide extended release once a week. Then we have dulaglutide once a week, and also the once daily liraglutide. The longer ones, the shorter ones, acting ones are the exendin based therapy, and the long acting ones are the dulaglutide and liraglutide, which predominantly affect the fasting hyperglycemia. And real world clinical outcomes intensification with GLP-1 receptor agonists, what we find is that there is a significantly more patients reaching A1C target with adding GLP-1. Significantly more patients had no weight gain or more than 3% weight loss with GLP-1. Significantly more patients were able to discontinue more than equal to 1 OAD with GLP-1. And look at the composite outcome, which again is very much importance. Significantly more patients achieved composite targets along with discontinuation of at least 1 baseline OAD. So the pill burden is going down, the composite outcome, the body weight, A1C, all of them are getting addressed in a positive way. Look at the multifactorial mechanisms. It acts on the insulin secretion, glucagon suppression, natriuresis, diuresis again is important. It reduces the appetite, and also the anti-apoptotic, the BCL2 and BAX2 are stimulated by this GLP-1. There is reduction of inflammation, coagulation, postprandial lipids. The left ventricular function is going up. The beta cell survival and function is going up. And also there are theories to suggest there is a potential neuroprotection. So what exactly the hard points that we are able to achieve? There is a reduction of A1C, reduction of body weight, reduction of blood pressure, CV events, hepatic injury, albuminuria. And for cardiometabolic benefits, as I was stating, we have become miser in our expectation from anti-diabetic drug. There is a reduction of all the three parameters of the glycemic triad: minimal hypoglycemia, reduction of weight, CV benefits are there, tolerable side effect profile, and approved for wide variety of patients. The wonderful talk presented by my previous speaker. Yes, we need to be aware of the limitations of the drugs. So what exactly has been done to put a peptide in a pill? The challenge is that, yes, the large molecule injections, fear of injection is still remain a barrier to use of GLP-1 receptor agonists for both the patients and the physicians. And if you look at the global internet survey of 1,250 physicians reported having too many injections is associated with poor adherence to treatment in patients, where 26% of the doctors agreed. We had vial and syringe, then come the tailored engineered pen injectors, then oral form of tablet. And as we move further towards the right end of this arrow, there is an increase in patient convenience. The rationale is that there is an unmet need for safe, non-invasive and convenient mode of therapy, where there would be increase in compliance and would expand the treatment options, early commencement of treatment, better patient outcomes, and that is the barriers associated with subcutaneous administration. So why it is challenging to give orally a peptide drug? First of all, there is enzymatic degradation in the stomach because of the low pH and the proteolytic enzymes that are in the gastric juice. Then we have limited permeability across the gastrointestinal epithelium. Apart from that, they have very low oral bioavailability. So these are the challenges when we try to give a peptide orally. So the Novo people, as we all understand, taught to us during our endocrinology days also, they are very good at attaching a fatty acid chain. So here what you can find is that the T half is 1 week with 94% homology to human GLP-1. The amino acid substitution at position 8, alanine to alpha amino isobutyric acid, protection against DPP4 degradation, and amino acid substitution at position 34, lysine to arginine, prevents C18 fatty diacid binding at the wrong side. And the fatty diacid chain to lysine at position 16 provides strong binding to albumin. It was a discovery which led to the path-breaking innovation in bringing GLP-1 receptor agonist in a pill. So this is the semaglutide, the most effective GLP-1 are tested to date. Long half-life of 1 week. We have studies where it is studied once a week therapy also. Then the SNAC, the sodium N8,2-hydroxybenzoyl aminocaprylate, is the absorption enhancer which is tagged to the semaglutide, which promotes absorption across the gastric epithelium and enhances semaglutide oral bioavailability. And when you have these two in one pill, this gives rise to oral route of first-in-class oral GLP-1 receptor agonist. Bioavailability is possible with an absorption enhancer because the variability, if it is not getting associated with a SNAC, the bioavailability is low and the variability is in absorption is higher, mitigated by 1 week half-life and once daily dosing, several treatment doses, patient compliance with dosing conditions. So SNAC is an enhancer that facilitates absorption. The available data for semaglutide co-formulated with SNAC support that absorption takes place in the stomach in a localized buffered environment, and the effect is strictly time dependent and occurs primarily via transcellular route. Absorption takes place in the stomach. You can see from this graph published in 2018, plasma semaglutide concentration was measured by the liquid chromatography mass spectroscopy. The time profile confirmed early systemic absorption and apparent slow elimination once present in the systemic circulation. Absorption of oral semaglutide in stomach requires co-formulation with SNAC, and SNAC causes a local increase of pH, leading to greater bioavailability, higher solubility, and protection from proteolytic degradation in the stomach. And also the effect is time and concentration dependent and is fully reversible. Approximately 1% is absorbed, the rest is degraded in the GI tract. Still, what you are getting, the exposure response relationship between the oral and the subcutaneous is almost similar. You can see both the graphs are getting superimposed. And why it is convenient for you? No dose adjustment regarding renal or hepatic impairment, no dose adjustment in elderly, and low risk of hypoglycemia across the pioneer trials. That's what we have understood. When should it be taken? Take when you wake on an empty stomach, wake up and take your semaglutide tablet straight away with up to half glass of water. Wait for 30 minutes before eating, drinking, or taking any other oral medication. 1 month, 3 milligram per day, then 7 milligram per day for another month. If you require dose escalation to get better glycemic control, you can get it to 14 milligrams per day. And very importantly, the missed dose, they should skip the missed dose and take the next dose as scheduled the next day. So that brings me to the summary of the presentation. Peptides are indeed challenging compounds and require engineering to optimize their in vivo performance. So the SNAC has come as a, I can say, Santa Claus for these Novo people, where it is combined with the semaglutide, and it basically protects the, it increases the pH and protects the semaglutide from proteolytic degradation. It also enhances transcellular absorption. There is a prolonged T half-life, there is a better stability, and mechanism of absorption is shown to be compound specific, transcellular, and without any evidence of effect on tight junctions. So oral semaglutide, we all have been looking forward. The trial, if I recall it properly, it was published in NEJM in 2019. And we all have been waiting eagerly. It represents an advancement in treatment possibilities for chronic diseases by transforming injectable therapies to tablet-based oral formulation. And as my previous speaker was also alluding to, it can be given in a wide array of patients, including the elderly, patients having hepatic and renal impairment, without much issue of hypoglycemia. And the biggest strength is that we all are very much tuned to the advantages of GLP-1 as agonist, weight gain, the hypoglycemia, the spectrum of cardiorenal protection. But then the injection was the main barrier. That barrier is significantly getting addressed by this wonderful molecule. Thank you all for the patient listening. Over to the organizers.
Taking Rybelsus properly is important for adequate absorption. It must be taken on an empty stomach with a sip of plain water. Rybelsus is co-formulated with an absorption enhancer that works to locally buffer the acidic pH of the stomach and increase transcellular absorption. Waiting less than 30 minutes or taking with food, beverages, or other oral medications will lessen the effect of Rybelsus by decreasing its absorption. Waiting more than 30 minutes to eat may increase the absorption of Rybelsus.
Thank you, sir. We would come back with the questions and queries at the end of the session. In the meantime, let us invite Dr. Mithun Bhartia for his talk on pioneering evidence of oral semaglutide translating research into clinical practice. Dr. Bhartia is a well-known endocrinologist practicing in Guwahati. He's MRCP with a CCT, and he's a Fitzwiller Fellow of the Mayo Clinic USA and AFA-CSM from Amsterdam. He is a national faculty at most of the prestigious conferences in diabetes and endocrinology in India. Started Practical Endocrinology Conference in the Northeast, which is the torchbearer of academia in diabetes in Northeast, and represented Endocrine Society in the British Parliament, numerous publications in international journals and national journals, author of various chapters in the textbook of diabetes, received prestigious awards like Rising Star Diabetes UK and India, International Fitzwiller Scholar USA, and T. Newman Prize from Chicago. Uh, well, legion of accolades to its name. Gaining in weight nowadays, my friend. So, fit candidate for Rebelsus, perhaps. Over to you.
Thank you, Soumik Bradada, and I think it's a real honor that to speak in his meeting. I remember going to a physical meeting in Calcutta. I think it was a couple of years ago. Well, I just get my
2018.
2018. Dada looks the same. In fact, he's going on diminishing age, reverse aging, as they say. So let me get my slide deck up. Okay, so what have I done now? Okay, it's gone the reverse way. Okay, is my slide deck visible, Dada, and moving? I think so.
Yeah.
Thank you so much. I'm going to speak on oral semaglutide. Sunil has already spoken. He's a good friend of mine. I'm just going to pick it up from where he's left. Now we're going to talk about the various trials that have been there, and we're going to divide the whole meeting into three parts of it. It's a sponsored meeting, so that's my financial disclosure for the same. I think in every era we live in something that has come that is new, and you've witnessed the same of it. There was Nehru era, there was Modi era, and I'm sure this is oral Rybelsus or oral semaglutide era. I think this is a revolutionary drug and with a revolutionary action, and it has been and a lot of data has come out. More than 5,700 people have been exposed, and a lot of data has come out. So I'm going to divide the trials into the 3A clinical program into few heads. So Pioneer 1 is with placebo, Pioneer 2 with SGLT2, Pioneer 3 with DPP4, Pioneer 4 with other GLP-1 receptor agonist, Pioneer 7 with a flexible dose adjustment versus DP4 with extension, Pioneer 8 with insulin, Indian 51 patients. Then we have Pioneer 5 renal impairment, Pioneer 6 CVOT, Pioneer Japanese trials of 9 and 10, and SOUL, which is ongoing to look at a superiority cardiovascular outcome trial. So basically what I'm trying to say, it's been studied across all significant good drugs that has been there. We are not comparing it to some feeble drugs, which is most of the trials I found that they do. It's been studied across. It's been studied across good drugs, and that is where we're going to see the evidence. I remember when I was in England, it was told to me कि भाई GLP, at that time we had oral subcut exenatide, and the thought process many years ago was that more than duration of 5 years of diabetes, GLP-1 will not work. So let's look at Pioneer. What was the baseline characteristics of all people? So something which is common in all the Pioneer studies, you will see that HbA1c was around 8% or more, and the duration of diabetes varied from 3.5 to 14 to 15 years across the various programs, and so did the age group. So it had a wider age group, right from 55 to 70 years that are there, and most of the patients who had where BMI was more than 30 kilogram per meter square. So these were the baseline characteristics, fairly, as you can, rough guide that we can bring in all together. Now, whenever we do a study, it's always important to know what is the end point. What are you trying to find out from the study? So Pioneer 1 to 5 and 8 has change in HbA1c as the primary point, and secondary point was change in body weight. Pioneer 6, as we know, was randomization and was an event-driven trial, not a time duration trial, and it was time to first 3-point MACE and secondary endpoint was time to first expanded composite CV endpoint, and Pioneer 7 was patients proportionate receiving target HbA1c less than 7%. Now, what is important or what is really nice to look at, it worked across all the Pioneer trials with a baseline of around 8%. The HbA1c was reduction. Average was around 1.5% give and take in the various trials. Fairly remarkable reduction of HbA1c that has been there against powerful agents that we use. We are not talking about old, people will compare with old agents. Now, fresh off the market, it's like comparing, a new batsman has come and you're comparing him with Virat Kohli and Rohit Sharma, and then he's scoring better than that. That is what has come out of these trials. And we had 7 out of 10 patients hitting the target of HbA1c less than 7%, which is what our desirable outcome is of any molecule. And the post hoc analysis of patients, if you look at patients who had an HbA1c more than 9%, the reduction was up to 2.6%. Yes, all of us has put patients on oral Rybelsus, on oral semaglutide, and we shall all want to know what happens in our data with our patients. But with this post hoc analysis, it showed more than 2%. And it showed better time spent in glycemic control versus SGLT2, which is a very strong or fairly useful product that we use on a daily practice that is there. Now, we all like to lose weight. Tell me, if I get diabetic, fingers crossed, I would like to use a medication which gives me all the benefits plus the bonus of weight loss. Who doesn't want to look nice? And across the global pioneer trials, it achieved a weight reduction of up to 5 kilograms. And in the post hoc analysis, significantly more number of patients achieved weight loss greater than 5% as compared to placebo and comparators. Now, why more than 5%? When I was in England, there was nice guidelines on obesity and various guidelines across the world, and Sunil has attended the scope, and we have all attended online scope training. We know that 5% reduction carries a significant reduction of mortality and morbidity of the patients, and it minimizes a lot of risk factors. So that's a target to aim for most of our patients that we like to do. Now, when we are going to cricket World Cup and everything, we all want all rounders. We want somebody who will reduce the HbA1c, who will also cause weight loss. Because at the end of the day, we are greedy for our patients. We want the best thing for our patients. We want one thing that we can do everything. And the post hoc analysis, higher proportion of patients could achieve the dual target of reduction of HbA1c of greater than 1% and weight loss of more than 5%. And the odds ratio, as you can see, was significantly higher with oral semaglutide, trying to achieve the twin bowling and the batting of both HbA1c and the weight loss, because there's a fine balance that one needs to do. If we look at the Pioneer 6 trial, oral semaglutide achieved its primary endpoint with 21% non-significant risk reduction, which was there. The HbA1c and body weight decreased more in the oral arm as compared to the placebo arm, and there was more drugs used in the placebo arm as well. People talk about Sustain 6 and Pioneer 6, but one must understand you can't compare an apple with an orange. They were different trials looking at different things. One was event driven, one was time driven. And I think, yes, further data we shall know with the SOUL study and furthermore data that is going to come out. Now let's dive a little bit deeper. As I told you about diabetes duration, and I think this is important because there is a thought process in mind. 5 saal, now I think it's gone on to 10 years or 15 years, GLP-1 or DP agents will not work. But what this has shown that HbA1c lowering is independent of the duration of diabetes. It does not matter how long the patient had diabetes. It works in all the duration of diabetes that are there. Now, something which is very close to our hearts is our parents. I came back to India for my parents, and we want a molecule which is safe for our patients, because aging population is a different population profile as such, and we look after them. And what it has been shown, the reduction of HbA1c was generally larger across all age parameters that are there that can be done. Now, if you look at HbA1c that was then on background medication, it irrespective of what the patient's was medication, Pioneer 3, 4, 5, 7, and 8, we could see it was lowering independent of background medication. The p-value was significant. Even weight layering was independent of the background medication, the Pioneer 3, 4, 5, 7, and 8 that are there. Now, Asian population, we are a little blessed, as in placebo-controlled trials of Pioneer 1, 4, and 8, Asians had a better HbA1 reduction as compared to other races. So, we have blessings, we have, God is with us in a lot of things in life. So in summary, what we are looking at is if this molecule can be given in all patients, renal or hepatic impairment you can give, early therapy, middle therapy, late therapy, you can give in all therapies. It has got cardiovascular safety. Adverse effect is mild to moderate nausea and is consistent with the class of the molecule that are there, and the reduction of HbA1c is better and superior to gliptins and SGLT2, and the weight reduction is superior to sitagliptin, liraglutide, and empagliflozin. Now, one talks about gliptin and GLP-1. GLP-1s always are a more powerful agent, bada baba or badi goli, more stronger action than a DP4 against any day that is there for patient. Now, the question often asked in meeting, भाई किसको दे सकते हैं और किसको नहीं दे सकते हैं? So in the question that comes for oral semaglutide, the only question that I have in my mind, who I do not want to give this medication, or who otherwise I think you can give this medication to everybody on patients taking more than one or more oral antihypertensive second line agents, in where hypoglycemia is a concern, with established cardiovascular high risk, established renal hepatic dysfunction, older patients. Only type 1 diabetic patient I would be very careful. I would not even give at this stage of to any patients oral semaglutide in patients who have type 1 diabetes, and I would be more careful to give patients who have got GI problems. So I think that would be the marker. GI problems definitely, and definitely, patients with type 1 diabetes, I'm not going to give. That is there. You see, if you look at the ADA data or ADA, we all talk about ADA standards of care or what they have said 2019, 2018, 2020. I don't believe guidance are for us clinicians, they're for nurses. But anyways, even if you look at, the world was divided into before Christ and after Christ, with low cardiovascular risk and high cardiovascular risk. But the beauty of the drug of oral semaglutide, it fits in both places, that you can be given in patients at low risk and patients at high risk. And that is what is going to be a game changer, because there is no problems with renal function, even not though it's not recommended for end stage renal disease, but no restriction of oral semaglutide regardless of renal function that are there. So in summary, we've got, and I'm sure all of us have put patients and all of us are very eager. In fact, I have one patient who just called me this morning. He's been on 3 weeks now on oral Rybelsus plus an SGLT2 inhibitor. He's lost 1 belt size on his waist and his sugar is better. And his daughter actually quoted him, said, Baba, you are looking very handsome and you are looking very positive nowadays. I think that is what is the game changer is going to be with this oral agents. So overall, if I say, it's a very effective medication, it's a safe medication, and more than that, it is a scientific breakthrough in innovation. I think I congratulate Novo for bringing innovation. I think it's one of the companies which brings innovation in diabetes care, and it has proven its worth when it comes to comparing with other agents, comparing with the duration of diabetes, and with a fantastic reduction of HbA1c. And we shall all look out for our own data, and maybe same time in the next conference of Soumik, we'll be able to present real world data of Indian patients as to where we are with the data, with our own experience, and recommend people how to use it. Thank you so much, Soumik, again for the opportunity. Thank you so much.
Thank you, Mithun, for being a T20 player and completing your session 5 minutes ahead of time. We have both the speakers have done an excellent job. And
Taking Rybelsus properly is important for adequate absorption. It must be taken on an empty stomach with a sip of plain water. Rybelsus is co-formulated with an absorption enhancer that works to locally buffer the acidic pH of the stomach and increase transcellular absorption. Waiting less than 30 minutes or taking with food, beverages, or other oral medications will lessen the effect of Rybelsus by decreasing its absorption. Waiting more than 30 minutes to eat may increase the absorption of Rybelsus.
So we will take the questions after our young friend, Dr. Arindam Pandey, interventional cardiologist from Medical Super Specialty Hospitals, comes with his take on pioneering oral GLP-1 receptor agonist in cardiovascular risk management benefits beyond glycemic control. Speaker is Dr. Arindam Pandey. who is a consultant interventional cardiologist, Department of Cardiology, Medical Super Specialty Hospital, as I had already stated, author and co-author for 7 chapters in various cardiology books, completed 10 research projects in the field of cardiology, and more than 40 publications in peer-reviewed national and international journals. He is a reviewer of many index medical journals, including Indian Heart Journal and BMJ. He is the first place winner in the TCT International Fellows Challenging Case Presentation, Washington, October 2016. Best Case Presentation Award, TCTAP 2016. There's a 0 more, sorry for the typo. Seoul, Republic of South Korea. Over to my young friend, Dr. Arindam Prande.
Thank you very much, Dr. Raichodhuri. So the topic which I have been allotted is basically, just a minute, please. So the topic which I have been allotted is pioneering oral GLP-1 receptor analog in cardiovascular risk management. So the benefits beyond glycemic control. So thank you very much for giving me this platform to deliver the talk. The financial disclosure, yes, this program is sponsored, so I do have financial disclosure. Now, my agenda is cardiovascular mechanisms of oral semaglutide, how it works, what are the things it does apart from lowering the HbA1c. Then I'll briefly talk upon the pleiotropic effects of oral semaglutide and its benefit across type 2 diabetes spectrum. And then I briefly summarize whatever I deliver today. So coming to the cardiovascular mechanism of oral semaglutide. Now, as we all know, there cannot be a single mechanism because yes, the predominant mechanism obviously will be to reduce HbA1c, but apart from that, it affects in the insulin resistance. So insulin resistance, as we all know, is very important pathophysiological mechanism of type 2 diabetes management. And then it also reduces body weight. While doing so, it also reduces inflammation. I'll show the data from various trials, how it reduces inflammation, what are the evidence. Lipid parameters are also improved. Say, for example, the triglyceride component as well as VLDL component is reduced, and there is also effect on LDL. There is direct effect on the myocardium and endothelial function, which is very important, particularly for the development of atherosclerosis process. And as we all know, it has some effect on the blood pressure. On an average, across the different trial, it has shown to reduce blood pressure to the tune of 5 millimeters systolic blood pressure with the dose of 14 milligram per day. So that is quite a significant reduction of blood pressure. And there is also reduction of hyper and hypoglycemia. So basically, the molecule works by increasing the insulin secretion from the beta cell, also by suppressing the glucagon. But very interestingly, it never produces any hypoglycemia because the insulin secretion, whatever happens, is basically, it is quite nicely related to the food. So in fed state, it increases the insulin secretion. In other empty stomach, it actually do not increase the insulin secretion. So with this particular molecule, there is no issue of hypoglycemia, which is very, very important and relevant for cardiologists like us, because we do not favor molecule which causes hypoglycemia. Because as you all know, hypoglycemia, during the spells of hypoglycemia, many autonomic dysfunction actually takes place, and this autonomic dysfunction can actually lead to some fatal arrhythmia. And some of these arrhythmia, if say for example ventricular tachycardia or ventricular fibrillation, can actually lead to sudden cardiac death. So being a cardiologist, I am very, very fearful about the hypoglycemic spell. So I always choose molecules which do not come with hypoglycemic effect. So this molecule, though it actually works through the insulin, but it never produces hypoglycemia. So that is one of the very fantastic benefit of this molecule. Now, all this mechanism, insulin, reduction of insulin resistance, reduction of body weight, inflammation, improving the lipid metabolism, and the direct effect on the myocardium, improvement of the endothelial function, blood pressure reduction, and the hypoglycemia reduction or hyperglycemia reduction actually leads to anti-atherosclerotic effect. So this anti-atherosclerotic effect, which is actually the main problem with long-term diabetes. As we all know, diabetes accelerates the atherosclerosis process. So by using this molecule with this different mechanism, the anti-atherosclerotic effects are seen, and that leads to cardioprotection and all the CV benefits, which has been seen across different GLP-1 analog trial. So as a result, we can see various effects. We can measure them. Cardiac output improves, cardiac contractility improves, endothelial function, it improves heart rate, and ischemic tolerance also improves. Plaque stability, there has been animal study which shows that plaque regression is also possible with this molecule. I'll briefly touch upon them. So anti-atherosclerotic mechanism of GLP-1 analog, yes, it has a direct anti-proliferative effect, which is important. It has been evidence from it has been evaluated in animal study. It also has directly effect on an endothelial dysfunction. It improves it. There is a more production of nitric oxide, reduction of ROS, that is reactive oxygen species, and by that it actually reduces inflammation. Now in gut, it also reduces free fatty acid secretion. So by that also there is some effect. And very importantly, in brain, as you all know, it suppresses the appetite. So the body weight comes down. So as a result, there is reduction of atherosclerotic plaque burden, plaque volume. In animal study, it has been evaluated and found to be very, very effective. These effects are actually beyond glycemic control in diabetes patient, and they address the cardiovascular risk with atherosclerotic cardiovascular disease risk modification with direct and indirect effect. Now, these are the different clinical trials. My previous speaker has already very nicely elaborated it. So Pioneer 1, from starting from Pioneer 1, which was actually with placebo, followed by Pioneer 2, 3T2 inhibitor, DPP4 inhibitor, and Pioneer 6 is the cardiovascular outcome trial, though it was a non-inferiority trial. So it met its primary endpoint. And very important, SOUL trial, which is actually designed for superiority, is undergoing. And in this SOUL trial, there is around 800 Indian participants, which is very important. So we will have very good representation of our own population, how they actually fare. Now, how much reduction of HbA1c is seen with this molecule? In different Pioneer trial, we can see around 1.5% of HbA1c reduction. So it is a very, very potent anti-diabetic molecule in terms of at the end of the treatment. If we see different Pioneer trials, Pioneer group of trials, so we'll find around 5 kg of weight reduction. So 5 kg weight reduction is very important. Now, I just want to mention one very important point when we compare this molecule with SGLT2 inhibitor, which are also very important molecule for weight reduction and favored by cardiologists because of its fantastic effect on the heart failure. But in our experience, we have seen the initial reduction of weight with a SGLT2 inhibitor is very profound, but later on the patient actually catches up. The weight actually goes up in long run. Whereas if we use this GLP-1 receptor analog, the persistence of weight reduction is actually better than SGLT2 inhibitor. So that is a very important difference between the weight reduction of SGLT2 inhibitor and GLP-1 analog. Now, if we talk about the Pioneer 6, which was the non-inferiority cardiovascular outcome trial, so primary endpoint, which was composite of 3 individual endpoints, the non-fatal MI, non-fatal stroke, and cardiovascular mortality, the primary endpoint was actually reduced, less than 0.0001. So it was statistically significant in terms of non-inferiority. So we can see in placebo arm, there was 76 events which was observed, and in the semaglutide, oral semaglutide arm, 61 events were observed. But the p-value for superiority was not met. That is why the next trial was designed. So there was 21% non-significant risk reduction compared to placebo. This is in terms of primary endpoint. Now, if we talk about the individual components of the primary endpoint, the first non-fatal stroke, there was significant reduction. with a hazard ratio of 0.74. So there was 36% reduction of non-fatal stroke, first non-fatal stroke. The cardiovascular mortality reduction was also very significant. We can see the hazard ratio of 0.49. So there was 51% relative risk reduction of cardiovascular mortality. But one thing which was actually catching the eye is the first non-fatal myocardial infarction. So there was no reduction of first non-fatal myocardial infarction. This is some of different. All the GLP-1 analog, they are actually very strong. They are actually proposed as very strong anti-atherosclerotic drug, but even with that fact, the first non-fatal MI was not reduced. This is the fact which we observed in this Pioneer 6. Yeah, definitely this is going to be cleared up in further and subsequent trials, but it was if we look at the hazard ratio, so it is 1.18. So mean of hazard ratio was more than 1. So that is how it is, but there was very importantly, reduction of cardiovascular mortality. 50% cardiovascular mortality reduction is not a matter of joke. And not only that, all-cause mortality was also reduced to the tune of 50% compared to placebo if we use as oral semaglutide. So all this data, though even if the fact that this trial was a non-inferiority trial, but this fact that they have very important reduction of mortality actually boosts up our confidence in this molecule. And this is something new I'll show. This is the pooled data. So pooled data of both Pioneer 6 and Sustain 6, as we all know, injectable as well as oral semaglutide. So both, if we take all the data of semaglutide, be it oral or injectable, then we analyze, we'll find that individual trial data and post hoc combined analysis, it is showing that cardiovascular event as a whole, cardiovascular mortality was significantly reduced. Though the non-fatal myocardial infarction, if we take as a whole with injectable and oral, we can see the hazard ratio is actually less than 1. So there was some reduction to the tune of 12% relative risk reduction if we combine injectable and oral semaglutide, but with oral, actually the hazard ratio goes up. Similarly, non-fatal stroke, there was fantastic reduction overall. 35% relative risk reduction of non-fatal stroke. I'll briefly touch upon why this thing happens. So what is the mechanism of reduction of stroke? So as a whole, the incidence rates of major adverse cardiovascular events were 3.1 and 4.2 events per 100 subject year with semaglutide and placebo respectively, with 24% reduction in the 3-point MACE. So this is very encouraging data. So if we combine both injectable as well as oral data. Now this is the post hoc exploratory subgroup analysis of Sustain 6 and Pioneer 6 patients on metformin versus no metformin. We can see whether the patient is on metformin or not on metformin, the benefit actually is similar. This is rather a little more important because if we compare this with the SGLT2 data, then we'll find if we combine SGLT2 inhibitor with metformin, the cardiovascular protective effects actually comes down. How it happens, I'm not sure, but some evidence is there which tells us, whereas no such thing actually is seen with this oral or injectable semaglutide, which is rather very important finding. Now, if we summarize the cardiovascular safety of oral semaglutide, so when oral semaglutide is added to standard of care, there is 21% relative risk reduction of overall MACE, 51% cardiovascular death reduction, and all-cause mortality reduction of 49%. HbA1c reduction was very good, around 1.5%. Body weight reduction was also very good, around 5 kilo versus placebo. And overall adverse effect profile was consistent with other GLP-1 receptor analog class. So I already mentioned that non-fatal stroke reduction was seen both with oral as well as injectable semaglutide. So there are now proposed molecular mechanisms for it because we can see what are the possible mechanisms during stroke. So what it does, it has a very nice effect on the reduction of inflammation, endothelial leakage, which can be important in this kind of stroke situation, and excitotoxicity. At the same time, there is the reduction in the reactive oxygen species production. So neuronal regeneration apoptosis actually is helped, and impact on the cognitive function of outcome and increased cerebral flow is also seen. So these are different possible mechanisms by which this group of molecule has very favorable effect on reduction of stroke. So semaglutide reduces the incidence of stroke, and the cumulative incidence of stroke over time is significantly reduced to the tune of 32%. So that is very, very encouraging finding. Now, as I mentioned, I'll briefly discuss upon the pleiotropic effect of oral semaglutide now and its benefit across type 2 diabetes mellitus. So first and foremost is the systemic inflammation, because now we know atherosclerosis and inflammation are very, very closely related. So if we see the different data, say for example, Pioneer 1, Pioneer 2, we can find that there is inflammatory markers such as hsCRP was markedly reduced with use of oral semaglutide. And not only that, I already mentioned in my talk, lipid parameters was very, very favorably improved. We can see decrease in the postprandial lipid, say for example, triglyceride and VLDL, as well as ApoB. So these are the lipid we should nowadays look in postprandial state. So lipid profile in fed state are ideal to see for exact triglyceride level, and all these parameters were very nicely reduced with oral semaglutide. And fasting lipid profile, the LDL and all other things were also very significantly reduced with use of oral semaglutide. There was effect on blood pressure, I already mentioned, around 5 millimeter reduction of the systolic blood pressure was observed across the globe. Plaque lesion development, LDL receptor deficient mice, we can see this is the animal study which shows that there is definite proof of plaque lesion regression or plaque regression with use of oral semaglutide. So that's how I think I am almost at the last part of my presentation. If I summarize, in summary, the deciphering mechanisms for pleiotropic effects of this oral semaglutide, we have some targets, some intermediate effects, and the final effects. So insulin secretion, though it is considered to be most important mechanism of this molecule, then comes the glucagon suppression. Natriuresis and diuresis also are important. Appetite suppression is very useful for reduction of body weight. And there is some pleiotropic effect by which cell survival are actually improved. So if we look at the intermediate effect, we'll find that inflammation is significantly reduced as evidenced by reduction of hsCRP in different trials. Coagulation parameters are improved. Postprandial lipids are improved. LV function, myocardial effect, direct effect on the myocardium. LV function has been shown to be improving. B cell survival as well as function are improved, and there is potential neuroprotective mechanism. So as a result, final effect, if we look at the final effect, the reduction of HbA1c, which is to the tune of 1.5%, 5 kg reduction of body weight, blood pressure reduction to the tune of 5 millimeter systolic blood pressure, definite reduction of cardiovascular event, albuminuria reduction, as well as hepatic injury improvement. So all these things are actually final effect as a whole, which give rise to so fabulous and fantastic effect on the cardiovascular protection. So with that, I'd like to finish here. Thank you very much for hearing me.
Thank you, Arindam. Mithun is there. I would ask Dr. Deballo Shannal, Riddhish, and Dr. Ajoy Biswas to share their screens, please. We can have a 5-minute discussion before we close the day. Dr. Shannal, yeah, thank you for being there. Dr. Biswas,
yeah,
Riddhish,
yeah, excellent talk, Arindam.
Thank you, sir.
The only one question is, would you prefer using this molecule in a patient, as per current data, in patients with established cardiovascular disease, or as a primary prevention?
There is a question in similar lines. Just let me add this question to you. Someone with high cardiovascular risk on liraglutide or dulaglutide, would you prefer to switch on to oral sema just due to patient preference? Or if the patient doesn't complain about anything, would you consider?
So there is two way of looking into it. Already I have done it in one of my patient, every time he used to visit me, he used to say very single thing that I want to get rid of this injection. Doctor, please help me. And I actually told him, because SEMA took long time to arrive in the market. So I was giving him this hope for last 1 year around. And whenever it was available, first thing I did, I actually shifted the patient from this Victoza to oral semaglutide. He is happy now, though the price, I think, is little higher. Now, if we talk it in terms of science, we'll see the Pioneer 6 actually, in terms of non-fatal cardiovascular, non-fatal mitral infarction, there is no reduction. Though overall 3-point MACE reduction was there, and very interestingly, cardiovascular mortality reduction was there. Now, if we see it as a whole, that how it is possible, the molecule actually, it is supposed to act against atherosclerosis, how the non-fatal MI can increase, whereas in other trials, other animal study, we have seen the coagulation parameters are also favorably improved. So it is, to be honest, I'm not very sure why the data is like that. Probably because of that, the whole trials have been developed, it has been framed. It will give us further information, it will clear many of the other doubts, but as of now, we do have evidence in terms of non-inferiority. So non-inferiority, if we take that evidence, I think we can safely shift the molecule of injectable to oral one if patient actually is not willing to continue injectable. Otherwise, if the patient is happy, I'll still prefer to continue injectable.
Mithun, one question to you, Dr. Mithun. Can semaglutide address glycemic variability?
Yeah,
And
so
I would ask Dr. Sharnal to chip in also.
Okay, so GLP-1 as a class of molecule have done enough CGMSs, and I'm sure Soumik has done a lot of CGMS studies. It's a beautiful molecule which the class itself reduces glycemic variability. Now, oral semaglutide, I'm sure, will be not much of different. The new time in range concept, I would say, is the nice wine, old wine in new bottling that we always wanted, that we don't want hyperglycemia or we don't want hypoglycemia. More data, our own data will come out very soon, I'm sure, but I'm sure it reduces glycemic variability, and that itself stabilizes a lot of things, because glycemic invariability causes a lot of problems. And I would just add to Dr. Arindam on the first question is, I would agree with him. I would not rock anybody's boat if they, not try to repair anything if it's not broken. I offered to somebody who was on Victoza 1.9 and he said, "Sir, আমার তো সব ভালো আছে, আমি কেউ চেঞ্জ করবে?" ঠিক আছে বাবা। So you have to actually have a real valid point, which we leave it to patient choice for the time being till the sole data comes out.
Dr. Sharnal, the question goes to you. And to the, I'll come back to the others also. There has been a meta-analysis from Dr. Mohan and his group, which compared the Asian data with the Caucasian data. And he showed that SGLT2 inhibitors have a huge benefit in the trials that he chose in the Asian population in compared to the Caucasian population. And well, the benefit was not that much, perhaps. It was more in favor of the Caucasians when they looked at the GLP-1 data. Although in our real world evidence, you would agree, you were a co-author with me, we have seen that all the parameters were reduced much more higher in the Indian population in comparison to the A population. In Pioneer also, they have showed that Asian population, the reduction is more. Now you have empagliflozin, which reduces cardiac death. And you also have semaglutide. The primary reports say that it reduces cardiac death. Tomorrow being the local elections, so today I would like a vote from you. In which class of patients you would go for EMPA, which class you would go for SEMA, and I would go back to the other two panelists again.
Well, again, probably early on in the spectrum of diabetes, especially in recently detected diabetes in high-risk patients, and early on, definitely to prevent the atherosclerotic process and, the endpoint mortality. Obviously, semaglutide would be the choice. One important thing now we have with regards to GLP-1 is the fact that previously, when we tried to use a GLP-1, because it was injectable, most of the patients wouldn't accept it because of an injectable agent to be used early on, right after metformin. So that was the problem. So the acceptance of early use of GLP-1 was very limited. But out here, if the patients can afford, we can actually start these agents early on to prevent cardiovascular death and all-cause mortality, and probably MACE, as you can see. There's a benefit, especially the pool data, if you look at the pool data. Whereas with SGLT2 inhibitors, definitely it would be more in patients who have established cardiovascular disease and also later in the day, where it is most likely to have an hemodynamic effect to prevent heart failure and overall cardiovascular mortality. So if you have both the agents at your disposal, probably we would use this GLP-1 oral sema earlier and the SGLT2 after the oral semaglutide for additional benefit, especially in the later stages.
Mithun, your take.
Dada, you are asking me to choose Gurkha Rasgulla and Gurkha Sandesh. I would like both together to have it on my plate. But
yeah, that would
I would like to keep it to your purse.
That would be the best.
Definitely, patients with heart failure I would sway a little bit towards SGLT2. I think that is where the swaying will happen.
And somebody with cardiac disease, no heart failure, but a little bit of more of kidney failure also. What do you would do?
GLP-1. I mean, oral sema, GLP-1. I've always been a GLP-1 fan, irrespective of the company that is endorsed it.
No. Someone with renal issues and diabetes.
So the question is, I think
no heart failure.
No heart failure is there. If the albumin creatine ratio is quite raised, then SGLT2 first and then add on the GLP-1. The question is which one will add one first before the second one. That is what you're trying to tweak out. I don't have a clear answer, Dada. But to be honest, but if the albumin creatine ratio is highly elevated,
I think which one you talked about, you would look at the criteria to whom you would not give this drug. I think I would ask him to show his bank balance.
I'll tell you the reason why I say this, and it's a true one.
Yeah, I do agree with you. I do agree with you with standpoint of data and everything.
No, the reason why I'm saying this, Dada, when I started my practicing, I went to a rural area and the person came in a badly clothed, usme ched tha, peela tha, dhoti, and I was very skeptical of even writing Sitagliptin. So I asked the relative and he said, come out, whatever the land you see belongs to this guy. So from that day, I always tell them this is the price, this is the evidence, and let them decide. From that day, I've stopped deciding for the patient for the financial way and let them tell them. So, but what I have done, and I'm sure Dada, you're doing the same, I only put people on oral repulsors before counseling them. Are you ready to be on 6 months to 1 year? If you're not, don't go on it.
Yeah, I do put in a time frame of 1 year for all GLPs.
Yeah.
If you can afford it for a year, if you do not fall out. Dr. Sharnal, although I have seen people talking about 3 months, but I do not think you reap the benefits.
No.
Arindam, the next question is perhaps for you. Yeah, the next question which has come up is for you. Somebody with acute myocardial infarction and heart failure, and you have to treat, you are releasing the patient is not fully out of heart failure, unwilling to take insulin. Your choice of anti-diabetic armamentarium may be because the diabetologist at your center is on leave at that point of time. The endocrinologist is enjoying somewhere 3,000 square feet above the sea level.
So it's very important and relevant question actually. Now, if we look at the data with SGLT2 inhibitor, the post-MI situation, the data is neutral, actually negative data. Whereas now we do have evidence with empagliflozin in the form of emprise trial that we can start this molecule even during hospitalization. Yes, certain criteria needs to be fulfilled. Yes, patient needs to be off inotrope for 24 hours. There is no intravenous diuretics and the hemodynamics is reasonably stable. Then actually we can start SGLT2 empagliflozin in hospital. So nowadays we are doing it. We are doing it even in non-diabetic individuals because of the heart failure benefit. Because SGLT2 inhibitor now they are there in the heart failure algorithms. They are considered to be the fourth pillar of heart failure therapy. So from your point, yes, it is not about whether the patient actually wants to start insulin or not. Because of our own need, we are starting SGLT2 inhibitor in this kind of many patients. Now, what about GLP-1 receptor analog? Generally, as of now, I never started this molecule in this situation because of the very adverse side effects of nausea and vomiting. Patients are on multiple pills during post-MI or heart failure situation. They are on aspirin, they are on clopidogrel, ticagrelor, etc., high dose statin. So they are already having kind of nausea, vomiting, this thing. So I never tried this molecule in hospital. I always try it in a very stable situation when the patient comes to my OPD. So yes, I'm not very convinced to start them in the hospital, and there is no data as well. In acute setting, there is no data. So I'll go with conventional anti-diabetic, and yes, I'll give preference to SGLT2 inhibitor, and empagliflozin will have some age.
Same question to Dr. Sanyal. Yeah, tell me how much. Dr. Sanyal, same question to you. Are you comfortable starting a SGLT2 inhibitor in hospital? Or Mithun, take this first.
Dada, I'm not. To be honest, I wouldn't be able to. I would like the patient to be stable at home. More metabolically and hemodynamically and everything stable before I start anybody on SGLT2. Same goes for GLP-1 as well, as Dr. ENDIAB has said. The only reason I may prescribe on discharge is because if they have got insurance or anything, so that they can, it helps the financial load a little bit for a month's supply. But I would actually counsel them to start, at least a few days in the house when they're far more stable. Perhaps I'm not brave enough, but perhaps I would rather stay them on insulin for a little more period of time and make them a little.
Mithun, would you like to end with that proverbial saying that fools tend to tread where, angels stare not and things like that? No, beyond the jokes, and Dr. Sanyal, I think I am looking at your ceiling fan. Yeah. Are you comfortable? Starting SGLT2 inhibitors in an acute scenario? Dr. Pandey said 2 criteria: off inotropes, 24 hours, not hemodynamically stable. What about, would you look at the creatinines? Would you at all start, if you are going to start, would you look at whether the creatinine has stabilized? Because after an acute event, we very frequently see that the creatinine keeps jumping, although the patient externally has stabilized, not on inotropes. These are scenarios perhaps which might have a little bit of a glitch for SGLT2 inhibitors. Your take?
I still don't, prefer using an SGLT2 inhibitor in a critically ill patient.
So, Dr. Pandey, you lose the election. 3-1.
So, yeah, why we are discussing this? Because if we look at the heart failure patients,
there is one data which is coming up that at discharge you can use it. If the patient is very much stable, then you can use it, especially there is one data which is there in heart failure patients who has a very stable heart failure. So at discharge, you can use it. If the patient, probably with the caveat that the patient comes back for a follow-up within a short period of time.
So why it is important? Just I'll say a few words. Why it is important to start it in hospital? Because both the trials, heart failure, ARNI is also a big thing, paradigm trial. ARNI never was tried in hospitalized patient, acute heart failure. It was also initially tried in stable heart failure patients. Similarly, the SGLT2 inhibitor were never tried in this kind of acute setting. Why it is important to start in this acute setting? Because data shows immediately post-discharge, the initial 1 month, there is highest chance of recurrent hospitalization, and there is highest chance of initial early mortality. Now, by this time, it is quite very much evident that SGLT2 inhibitor and ARNI both are very, very favorable and fantastic molecule to treat heart failure. I'm not concerned about blood sugar. I'm talking about heart failure only. Now, from the point of heart failure, if you really want to cover this initial 1 month of post-discharge, you need to start the molecule either in hospital or very early after discharge. Now, very early after discharge, we do follow-up not before 2 weeks. In my practice, I always call them after 2 weeks. So out of this 1 month, if you lose this initial 2 weeks, then it is actually high risk. Many of the patients get readmitted for hospital, heart failure. So my take is, when the patient is dischargeable and very, very stable, if we can counsel, we can, ask the patient to stay for 1 more day and see whether this is doing any harm, immediate hemodynamic, any other things are going on. Then it is, if it is well tolerated, I do continue it. And that is why all the trial, all the pharmaceutical company, all the researcher, they are also evaluating this aspect of starting it in hospital, not for the sugar perspective, but solely because of heart failure.
Thank you, Arindam. Thank you so very much. And I am holding you back from your dinner plate, perhaps a bit too long. We are 10 minutes beyond time, but we finished in time, and the discussion took us this long, and the culprit perhaps is me. And thank you for all of you who have been there. Thank you, Mithun. Thank you, Arindam. Thank you, Dr. Kota in absentia. Thank you, Dr. Sunil, for joining in. And thank you also to Riddhish, who is on mute, and to Dr. Ajoy Biswas, who also is on mute. They refuse to be a part of this controversy, coffee or toffee. So good night to all of you.
Good night.
Thank you, everyone who has attended. Thank you for staying with us for so long. I hear from the platform people that there are still 70 people who are listening to this. Thank you, all of you, and see you again tomorrow at 4:30.
Thank you. Good night.
Good night.